Okay, welcome back, members. Welcome back, or welcome, audience. We had a very productive morning this morning. I appreciate everyone leading such exciting, energetic, passionate, and robust conversations in our subcommittee. So we've already solved all the world's problems this morning. We're all done. No, I'm thrilled to tell you that we have a really exciting agenda coming up for the better part of the rest of the afternoon. I also want to tell you some exciting news that Helen just shared with me. The National Alzheimer's Plan has just posted for 2025, and congratulations to everyone that worked so hard on it. These two folks right here, too, in particular. I also want to say, I think you said it was 18 pages? Of content, so that's digestible, folks. So I would suggest everybody take an opportunity to take a look at it. Love to get your feedback on that as soon as everybody dives in a little bit to that. Okay, so for the next hour, we are going to talk to our federal agency partners. There is so much work happening in many different agencies and different spaces in our federal government, and I'm really anxious to hear from them because we had so much information the very first meeting we had, so anxious to hear back from our federal partners. I'll turn it to Maria to get us started.
Thank you, Michelle. So we're going to kick things off with NIH, Dr. Richard Hodis and Dr. Amy Bainey-Adams.
Thank you. And can we move to slides? Yes. Thank you. Well, Amy and I are delighted to be here. Whoops. Sorry, but we're just jumping ahead. Okay. Well, I did want to take this time to report some updates, including this one, which is an intriguing recent one that Amy and I are both involved in. This reflects the importance of data that can come from many sources, including longitudinal studies and natural experiments. And what this refers to is the result of an experience. First report was from a cohort in Wales, which was in September, determined that anyone born September 2nd, 1933, or earlier was eligible for shingles vaccine. If you're born the next day, you were not eligible. And they had a good success then in immunizing those people who were ineligible. So you had a cohort differed by just a day in birth, potentially, who were or were not immunized. And they tracked those over the subsequent 7 years of follow-up for development of dementia and found there was a 20% decrease in the rate of dementia in that population. That was subsequently reported and repeated in independent natural experiments in England and in Canada. So we have this wealth of information now from epidemiology. It's not a clinical trial, but it's extraordinarily strong observational data. And in fact, I can share with the group the fact that in June, we're going to be holding a meeting to try to understand this, what the mechanism is, whether it's related to herpes zoster itself or to the effect of just priming the immune system, but an example of some of the exciting developments that can come from unanticipated sources. This is just another example of the way in which we try to promote research through mechanisms in addition to our conventional grant mechanism. That's why I show it here, using the challenge mechanism. So challenges are in contrast to grants. Grants, as you all know, involve submitting an application, proposing to do work, then being funded for that work, and then completing the work. The prizes are different. They actually present an award or prize for doing something. And in this case, this is the Eureka Challenge for early prediction of AD-ADRD, discovering new methods for early prediction of Alzheimer's-related dementias. And the applicants are often not typical ones. They may be individuals who have never been applying for NIH or, for that matter, federal government work. Here, the prizes were up to $100,000 to winning teams for a total of $650,000. And recently announced some of the winners. They looked at such things as speech patterns, demographic data from population representative studies, and shown quite impressive ability to predict outcomes. And you can envision how these might be successful in screening populations for further exam workup and need. So just a couple of examples of research of late. Now let me turn it over to Amy to talk about the summit. Oh, it's our summit, our summit. So 2026, so just last month, as you know, they have a series of summits. They are Alzheimer's disease summits, they are Alzheimer's-related disease summits, and they are Alzheimer's or dementia care and caregiving summits to deal with research needed to find the best means of caring for those living with disease and their care providers. There were nearly 600 invited attendees. The link to the recorded results are there for those who couldn't participate, and these generally then guide our identification of gaps in the area of knowledge, priorities for what comes next, and leading to our milestones and identification of priorities for further research. And now,
Thank you so much, Richard. I really appreciate the opportunity to be here today. Today I'm going to talk to you quickly about two recent studies that we supported that identified promising novel therapeutic targets for Alzheimer's disease and related dementias. And I just want to note that one of our highest priorities is trying to identify novel therapeutic targets because we are really crucially and urgently aware of the lack of disease-modifying treatments for these disorders. So on the left, we are talking about the role of lipids, actually. So lipids are compounds that include fats, and they exist in brain cells, and their metabolism is increasingly recognized as a significant feature of frontotemporal dementia, or FTD, and ALS. Polyunsaturated fatty acids, or PUFAs, which I just love, are a type of healthy dietary fat that's a critical component of the cell membranes of neurons, maintaining membrane fluidity. So the team observed that decreases in PUFA levels, but not in other types of lipids, were seen in human postmortem tissue and in multiple animal models of frontotemporal dementia, or FTD, and ALS. A decrease in these fatty acids would lead to a decrease in membrane fluidity. So then the membranes would become brittle and more prone to stress, and that could be one of the reasons why they degenerate in these disorders. Importantly, researchers found that by genetically restoring the polyunsaturated fatty acid levels, by expressing enzymes involved in the metabolism of these unsaturated fatty acids, dramatically reduced disease phenotypes in all of the animal models and also in induced human pluripotent stem cells. This suggests that enhancing these fatty acid levels in the neurons of people living with ALS and FTD could be a therapeutic strategy. And it also raises the possibility that lipid biomarkers can help with disease detection, stratification, and pharmacodynamic readouts of intervention. And then on the right, there is another recent study that I'm going to share where investigators looked at traumatic brain injury, or TBI, which is a well-known risk factor for related dementias, Alzheimer's disease and its related dementias. But the mechanisms linking the two are poorly understood. This study suggests that dysfunction of the brain's meningeal lymphatic system, which is the primary conduit for clearing waste and pathological proteins from the brain, is critical to the neurodegeneration seen following traumatic brain injury. The lymphatics are in the brain's outer layer, and they transport fluid and waste products, including toxic proteins like tau and amyloid beta, from the brain to lymphatic vessels in the neck. This system is twice as active during sleep, and that's one of the things that suggests that neurodegenerative diseases might be accelerated by the sleep disturbances that are experienced by individuals with these disorders. Using a mouse model, authors showed that a single mild traumatic brain injury was sufficient to worsen tau pathology and neurodegeneration, but introducing vessel endothelial growth factor C, which enhances meningeal lymphatic function by promoting growth, vessel formation, and functionality of lymphatic vessels. If that was introduced within 24 hours of the injury, this single treatment was remarkably effective, rescuing brain lymphatic damage and protecting against tau pathology and cognitive decline. Taken together, this study identifies this lymphatic dysfunction as a critical link between brain injury and neurodegeneration, and it suggests that VEGF-C is a promising post-injury therapeutic strategy. It also raises broader questions about whether restoring brain lymphatic drainage could be beneficial across other neurodegenerative disorders. And finally, I want to talk a little bit about the fact that, as you all know, by participating in this meeting here today, HHS often looks to accelerate progress by convening experts to review research progress and help identify new research priorities and exciting opportunities. And another example is a council established by the National Plan to End Parkinson's Act, which includes Parkinson's disease and related Parkinsonisms, including progressive supranuclear palsy and multiple system atrophy. This act is structured to parallel the National Alzheimer's Project Act. And like NAPA, it creates a council to create and assess a landscape of all federal research activities in these areas and to formulate a plan to advance research, care, and services. With thanks to Helen for her ongoing advice and guidance, we have navigated many bureaucratic steps during quite a tumultuous year, and I am pleased to share that we have successfully established the council and recently announced its membership. The federal members of this group have been meeting regularly, and the public members, including scientific experts, doctors who care for people with dementia, and the people with lived experience of the disease, will join in their first meeting on June 29th, which will be virtual and open to the public. The committee and NAPA will work closely together, I hope, especially in areas like Parkinson's disease dementia that are relevant to the work of each council. And I look forward to updating you on our progress in the months to come. Thank you. So I'm not sure who I hand it to next.
Yes, next up is Erin Long with ACL.
Oh, it's waiting for me to do that. So I don't have a huge amount to report today, but I did want to just sort of give you some basic highlights. In case you didn't know, May is going to be Older Americans Month, and this year for our theme, we had Champion Your Health, which obviously goes along with the Secretary's Make America Healthy Again. We're going to celebrate the contributions of older adults and reaffirming our commitment and the Aging Network's commitment to serving them since 1963. We're talking about prevention, wellness, and personal responsibility as cornerstones of healthy aging. I would say that everything we do, there's a thread of dementia that goes through everything at ACL, at the Administration for Community Living, as well as the Administration on Aging and the Administration or the Office on Disabilities. While I don't have anything to report immediately in terms of opportunities, I did want to sort of give you a highlight of what our anticipated programs that we're going to fund this year. We have our traditional state, community, and tribal grant programs. We've been doing those since 2014, and we focus on supporting people with living alone with dementia, people with intellectual and developmental disabilities, as well as supporting caregivers. Last year, we funded for the first time a program to support community health worker programs in the Aging Network to get to embed community health workers in the Aging Network and enhance the workforce that we're so desperately in need of. New in 2026, we're anticipating funding state programs for dementia-specific respite with great grants to states to be able to create programs to enhance typically what's been under the Older Americans Act funding to have actually dementia-specific respite available through our National Family Caregiver Support Program. We have, through the Alzheimer's Association, been funding support for innovations in dementia-specific respite programs, and they're seeing success in giving little small seed grants for organizations to create respite programs that are innovative with the expectation that some or all of it would be sustained beyond their federal funding. It's just, it's sort of helping people that have a wish list of what they would like to do, but if they just don't have the money to get it off the ground, but once they get it off the ground, they're able to sustain it. A lot of people don't know the Administration for Community Living actually funds about a quarter of the Alzheimer's Association's National Alzheimer's Call Center. We provide them with $2 million a year for that. And then we also have the National Alzheimer's and Dementia Resource Center that basically we fund all these programs all year long, and every year someone's rolling out, new ones are rolling in, and as programs roll out, they have all created things. So what we take the best of the things that are created and we put them on that website there. So there's all kinds of training and resources, tools, videos to support. We're super excited. There's one going to come in the next round that's ending in June that is creating a video series to support groups, so sort of discussion primers, that there's a short video of 8 minutes or something, and then it's the discussion for the support group, and then it's also going to have a facilitator guide. But so we have some really good things coming. Oh, I just did that. Just a couple of things. We have later this week, we have, actually this is the one I was just talking about, Can Do. We have a webinar on this Wednesday that's going to highlight that program I was just talking about with the strength-based support group model, Learning to Live with Dementia. So there's a registration link. I think that these slides will be available so someone could click on the link. But we're very excited they've been testing it in Southern Virginia, and we're excited that it's going to really come out to be something that we can be rolled out across the nation at a low cost, high impact. Another upcoming webinar we have is in May, addressing cognitive impairment and dementia among homeless and housing insecure seniors. We have a program in Arizona that is doing amazing things, working with homeless shelters. So they're going to talk about the work that they're doing in Phoenix. And then we have our own Helen is going to, in June, she is going to moderate a panel for us to talk about bridging healthcare and social service. I'm sure that's at the top of mind of many people in the room. For people living with dementia, we work together with ASPE and ACL to write a paper in 2024, and we're continuing to advocate to promote the findings of that. And then in September, we have another webinar coming up on meeting the emotional needs of dementia caregivers, providing an overview of mental health concerns of people living with dementia and targeting programs for caregivers, and working with, it's another grantee that we've been working with. Our program, typically, we highlight the work of the programs that we've funded. Just a pitch for our National Alzheimer's and Dementia Resource Center. If you can't find it there, just email me and we'll find what you need. And we do have also at ACL the National Caregiver Support Collaborative that is advancing the national strategy to support family caregivers. That's for caregivers across the lifespan. It's not just dementia caregivers, but like I said earlier, there's a thread of dementia through everything we do. And this is going to highlight the innovative practices to support family caregivers in navigating vital services and sustaining their well-being. It'll be the U.S. Aging talking about the way the Aging Network is addressing these needs. And that, too, is later this week. So if you don't already have a full calendar, we can fill it up, pieces of it for you. And then in November, the Secretary of Health and Human Services, Secretary Kennedy, announced the Caregiver AI Prize Challenge with ACL. And that is also underway with applications coming in July. And it's seeking responsible AI-enabled solutions to support caregivers and improve the quality of life for older adults and people with disabilities. And the first phase is up to $2.5 million for 20 winners. And then they'll continue to phase 2. There's a link on there that is, will link you to all the information. I do believe that they either have planned an informational call or they've already had it and a recording would be there. And then that's it.
Thank you so much, Erin. A lot of great stuff going on with ACL. So originally we had Kevin Cheney with AHRQ scheduled to speak, but due to an emergency, he's not available to speak. I know that his presentation focused on a systemic review that was published around Alzheimer's disease and Down syndrome, so we will share that information online later. And with that, we will move to Helen Lamont. I don't know if you had anything you wanted to add beyond Michelle's announcement about the national plan. Okay, so then we will go to Captain Fleetwood Lucillo with the CDC virtually.
Congratulations on the national plan. It's exciting. And, so I had a slide. I don't know if it's possible to be visible in the room or in the materials, but it mainly focuses on two updates around the BOLD infrastructure and National Healthy Brain Initiative. And it includes current activity in this FY of $41.5 million for FY26 funding. It's our highest annual investment to date. And we continue to fund 43 state travel and local and territorial health departments with specific activities within those. And they currently have the 3 centers of excellence that focus on early detection, risk reduction, caregiving. The top line as well for FY26 is we're forecasting a new NOFO that should be released in the summer that combines multiple funding announcements together to hopefully streamline some of those initiatives and help to better connect and coordinate across national partners. And just highlighting a few other activities of 20 years of the Healthy Brain Initiative progress with report we talked about previously, and continuing to fund as well the International Association of Indigenous Aging to adapt a roadmap for Indian country for tribal elders. And we just recently had the Behavioral Risk Factor Surveillance System annual conference or meeting at CDC, and states and state coordinators gathered together here in Atlanta. And we're excited to continue to support multiple modules on the Behavioral Risk Factor Surveillance System, including those capturing cognitive decline and caregiver trends. And these modules actually are captured on a number of states, 32 states for the cognitive decline, 27 states for the caregiver trends. Those are quite high numbers for modules that states have to opt into and also jointly pay for. So we're excited about those data being collected currently. And for additional data and data information, we have the Alzheimer's disease and healthy aging data portal that includes county level risk factor data. So additional data, not just at the national level, at the state level, but also getting down to lower levels of geography in which data can be provided to help comparison across different geographies. And then the last one was just the Behavioral Risk Factor Surveillance System conference that I've mentioned before. So tried to combine it all into one slide here for an update. I'm happy to address questions later on down the road, but I'm excited about these activities and also excited about the forecasted NOFO as well that's coming out hopefully later in the summer. Thank you.
All right, now we're going to turn to the Department of War, Dr. Dwayne Telefar.
All right, good afternoon, everyone. Here I am. All right, so I'll be very brief. I'm with the Congressionally Directed Medical Research Programs. We're part of the Department of War. Our funds come in addition to the Department of Defense's, the Department of War's budget. It's congressionally directed for various diseases and conditions, where Alzheimer's disease being one of those. So I'll just give a little advertisement here. So we have 34 programs in FY26. One of them being the Alzheimer's Research Program. We are appropriated at $15 million. This program is what we consider a solutions-oriented program where we're trying to develop new capabilities to help us understand, prevent, and assess Alzheimer's disease and related dementias. For this particular update, I just wanted to point out that our pre-announcement for FY26, which are funding opportunities we intend to put out, has been released. We intend to put out 3 funding announcements, the Transforming Care Award, Transforming Research Award, and Transforming Diagnosis Award. Currently, we are now in a holding pattern at the Congressionally Directed Medical Research Programs due to compliance with an executive order So we anticipate that our funding will be released, funding announcements rather, will be released within the next month or so. I do want to highlight a couple of things that are really important for our program. One of which being that we have a strong focus in the quality of life of those living with Alzheimer's disease and related dementias, as well as their caregivers. We also have a strong emphasis in community collaborations where we encourage the involvement of lived experience in the design and execution of our research. So again, I think this is my last slide, but the key point is that we have some funding announcements coming out shortly.
Thank you. And now we are moving to the Social Security Administration. They'll be joining virtually. Dr. Bob Weathers and Michael Goldstein.
Hi, can you hear me?
Yes, we can.
Great. This is Michael Goldstein on behalf of Social Security Administration and Bob and Megan Reeves, who are joining us as well. Thank you so much for having us as part of this. It's been a great experience thus far, and I look forward to it continuing. Next slide, please. So hopefully some of you recall the presentation we gave last time. We are a group of generalists, if you will, here, right? Applying the disability program, making the rules and applying it. But we have great resources, and one of those is through the National Academies of Science, Engineering, and Medicine with their standing committee. We meet with them quarterly. So one of our last topics that we did in our spring meeting with them was related to Alzheimer's disease. So it was a really great experience. We had a few remarkable presentations. We learned some of the progress in early diagnosis and biomarkers, prognosis and classifications, things along those lines. And one of the great elements of this is that the standing committee is comprised of medical professionals who are also well versed in our disability program, right? So they bring in experts. They're listed there, Dr. Albert and Carluish and Nina Cohen as well, with kind of a broad perspective, right, to teach us. And then they help us to understand the medicine, standards of care, and the like in the context of our disability program. So it was a really fruitful session. So we can, thus eventually take that information and hopefully potentially update various elements of our policy, but at the very least make sure the folks who are applying policy and adjudicating or determining whether an individual who applies for disability is in fact disabled, to make sure they're well equipped with all the information and appropriate knowledge and kind of techniques to go ahead and adjudicate those claims. So still early in that synthesis of all that information we got, but it was a really cool opportunity and great to meet those folks. Next slide, please. The other big piece that we were able to accomplish in the Alzheimer's space over the last few months since we saw you in early February was we did make updates to part of our program manual, if you will, related to compassionate allowances. I told you last time we met, at the time it was called our early onset Alzheimer's compassionate allowance listing or criteria, if you will. They're actually kind of information sheets, again, used by these generalists to apply this policy because they're not necessarily Alzheimer's experts, right? But we had been contacted by the Alzheimer's Association of America, had some contact with them, did our own research, did our own work, and we're able to make a lot of updates that they thought we should make and some others as well, right? Making sure we were kind of following the criteria we need to make sure that the people actually using the information are able to do so accurately and in a kind of streamlined process. Next slide, please. So besides the name change, we were able to update the alternate name section, information in the description section, right? So that the people, a lot of what our folks are doing are going through medical records. So kind of updating this information and the diagnostic testing and the progression information, it really helps them to be able to identify what they need to find, right, to accurately adjudicate this claim. And because it's on the compassion allowance list, it's also streamlined. So it is a great benefit for those who may be afflicted with young onset Alzheimer's. So we're really happy to be able to do that and to serve the population in that way. We're continuing to look for additional opportunities to advance our policies and our processes in this space. Got to meet Dr. Taliaferro last week, and that was awesome. So we're gonna keep going here. And again, I really do appreciate the time and just being a part of this great advisory council. Thank you.
Thank you. We're going to open up the floor to any other federal agencies that had updates. I know there's some folks who had planned to be here in person but are available virtually. I think IHS had a couple of comments. Jolie, are you on?
Hi, can you hear me okay?
Yes, we can. Thank you.
I hear me echoing. Yeah, thank you so much. Apologies, I wasn't able to submit anything in writing. There was a video link that I shared, and I might have shared it too late for you guys to show that. I'll drop that in the chat if we're not able to look at that today. You know, that's probably one of the biggest, most emotional things that we've done in this past quarter is we created a series of videos. There's one on advanced care planning that features South Central Foundation. We have a second one that features several of our staff as well as some participants from our grantees and our workforce development programs talking about the importance of early detection and screening and getting involved. And then the third one features a family from the Nez Perce tribe who wasn't diagnosed with dementia until 6 months before she passed away, and sort of the struggles and experiences of that family. And as part of that, they, as well as the healthcare providers who are grantee recipient, are recommending earlier detection and diagnosis and support in their community. So it's a really lovely series of videos. Perhaps you'll have a chance to participate, view those. So the other big thing that we had happen this past March is our Elder Care and Alzheimer's Workforce Summit. We had 223 participants from across the country, very well rated. I think 98% of the people who attended said it was an exceptional meeting, so we were really proud of that experience. We do also have a notice of funding opportunity that should be coming out in the next month or so. There's two options embedded in that. One is a Caregiver Training Services and Supports National Resource Center for tribal and urban Indian communities, and the second is called Dementia Cares. The focus of that is creating a national center who will provide mini grant funding, build a champion network, and gathering data from these efforts to help inform our other larger work. And the goal here is really designed to broaden our reach into improving direct clinical care and services. And I think that's probably the big stuff for you. So thank you, appreciate it, and sorry I couldn't be there today.
Thank you so much. And I did drop the video in the chat for those who are able to access that. And then I did get a question about the publication I mentioned earlier. Give me just a second to pull it up. So the systematic evidence review was published last month, and the title is Medical Care for Adults with Down Syndrome. And again, we will post that online. It'll probably be available in about a week or two. Thank you. Were there any other federal agency comments? I think we're a little bit ahead of schedule, so otherwise we can take a break.
Or I was going to just have the council members introduce themselves.
Oh, sure.
Hi, apologies, Sherry Lang, Deputy Chief Medical Officer for the Centers for Medicare and Medicaid Services. Also did not submit any formal slides or updates. We tried to reserve updates that are more specific to the care and keeping of people with dementia, but did want to also flag the agency just announced the regulatory alignment for predictable and immediate device coverage pathway, or acronym RAPID, and just wanted to flag that for folks because although not specific to Alzheimer's or dementia care, actually illustrates the processes by which CMS can consider new devices, and again, still in the statutory construct of what might be reasonable and necessary, but utilizing the pathways to gain efficiencies between our agencies, between FDA and CMS. What will be exceedingly important and something that we have all talked about over time is to be able to identify and know what those outcomes are that are really important and matter to the people who we serve. So people living with dementia, their caregivers, they have important input to determine what the outcomes are that can help frame the evidence as it is generated and as that evidence is used in policy making. So I did want to flag that. I think it will help gain efficiencies, permitting earlier identification and also knowledge of the process of how do you work with CMS. And this is really to support innovation, new product development, and the usefulness of those products as it applies to the Medicare population. So thank you so much. Over.
Thank you.
Okay, I thought it might be helpful because for those of you that weren't with us this morning, we broke out into our subcommittees. I might have shared that with you a little earlier. So I thought it might be because we have so many new members, let's just take a moment to introduce ourselves, say a little bit about us. But before we do that, I just wanted to say a special thanks to someone very important in the room who has made me a great deal smarter in the world of Alzheimer's disease, and that is our own Deputy Secretary, Carrie Eyre, who is also our State Dementia Director, and I think the finest in the land when it comes to dementia care, policy, everything under the sun. Just one of the greatest minds and the most caring heart. So, Carrie, thank you so much for everything. Okay, so we will start with Dr. Hannell.
Introduction?
You're just introducing yourself, saying hello, where you're from, what's your favorite color?
I'm Ricardo Hannell, born and raised in Brazil, American by choice, trained in neurosurgery, cerebrovascular, about to start a very exciting clinical trial for surgical treatment for Alzheimer's disease. Baptist Jacksonville in Florida. I'm glad, honored to serve. Thank you, Michelle, for the opportunity. I think it's phenomenal to be here with all of you and exchange informations coming. I think we can do a much better job when we come with all different angles and tackle epidemic that we have in our direction, that is Alzheimer's disease and related dementia. So thank you for the opportunity.
General?
Thank you, Chair. General James Hammer Hartzell, and from Florida, Veterans Affairs, and just every time I come to something like this, or I'm involved in something like this, I realize how much I don't know, and that just inspires and pushes me to do more. And that's why we had a wonderful clinical care committee this morning. I'm sure John Curris, our chair for our subcommittee, will be able to talk about it. But I now have tasks just from a short meeting we had this morning for me to go back with to find from the federal VA and other partners that I work with routinely. But now I want to do more in this space for Alzheimer's and other forms of dementia. So it's just a blessing to be here, honestly. Thank you.
Hi, everyone. I'm Helen Lamont. I'm in the Office of the Assistant Secretary for Planning and Evaluation, where I am the Acting Director of the Office of Behavioral Health, Disability, and Aging Policy.
And an amazing partner. Hi, I'm Michelle Branham. I'm the Secretary for the State of Florida. I was just recently Secretary for our Elder Affairs and just recently appointed by the Governor to lead his faith office as well. So pulling double and now triple duty, which is a great blessing and an honor. So very grateful to be here. And then Maria, another great partner.
I'm Maria Teresa O'Caffer. I'm also in the Office of the Assistant Secretary for Planning and Evaluation, and I am the designated federal officer for the Advisory Council Really glad to have everyone here and, be part of the great discussions.
Happy Monday, Christy Putnam. I currently serve as a senior fellow at the Cicero Institute in Health and Human Services, formerly the Secretary of the Arkansas Department of Human Services and Deputy Secretary in Kentucky. Happy to be here. Thank you.
Good afternoon. I'm Michael Mayo. I recently retired as Chief Executive Officer and President for Baptist Health in Jacksonville, Florida. I serve as the subcommittee chair for risk reduction on this group and also serve on the Board of Trustees for the American Hospital Association and the Florida Hospital Association as well.
Good afternoon, everybody. My name is Jonathan Weiss. I'm from industry. I have the privilege of being part of many companies, one of which pursues solutions, next generation technologies to help solve Alzheimer's disease, and to be among you guys from the careers and the politicals, to hear all the effort and resources that goes behind all of this. Like you, Hammer, there's so much information, inbound information, so it's really great to be sitting among the experts who own that information and to hear these different perspectives, so we could bring to the table new ideas and recommendations to advance solutions in this space.
Steve Waterhouse. I'm here with my wife, Gina. I guess my Alzheimer's career started in 2016 when she was diagnosed with Alzheimer's. I'm chairman of the board of the Alzheimer's Association for Central and North Florida, and it's a thrill to be here and have an opportunity to try to make a difference for those who are living with this disease.
And I wonder, online too, if we could grab John Corris, if he's online.
Yeah, I'm going to take myself off of video. Let's see if this works.
Ah, there he is. Hi,
Hey,
John.
everybody. Hey, sorry I couldn't be there. With all my technical difficulties today, I will not be coming in remotely going forward. I'll be present. It's a pleasure to be with you. I am the subcommittee chair of clinical services. I'm also the president and CEO of Tampa General USF Health System in Tampa, Florida, and it's been great to be with you. And I'm looking forward to the work ahead. I'm really looking forward to learning from others. What amazes me, and I'm not surprised by this, is the amount of resources the federal government has already provided to this disease and this illness. Part of my subcommittee's job will be to attempt, if approved, to sort of aggregate all of these great resources, educate and share them with both the providers, the physicians, and the patients that are dealing with and working within neurological diseases. And I'm delighted to be here and to contribute. Thank you.
Thank you, John. And I think we have Dr. Randy Bateman on the line as well.
Hello, I'm Randy Bateman. I'm a neurologist at Washington University in St. Louis, and I served on the last 4 years of the committee and serving as co-chair of the research subcommittee for NAPA. And we had a lively discussion this morning about our patients' needs and the needs for accelerating the discovery and the treatments for Alzheimer's disease.
Thank you, Dr. Bateman. So good to see you online. And then finally, I think we have Kate Newkirk as well.
Hi, everyone. My name is Kate Newkirk. I'm a licensed graduate social worker here in DC, actually, and I serve as the vice chair for our board. I'm also the subcommittee chair for the long-term care services and supports committee. I look forward to working with all of you. I'm very sad that I can't be there in person today, but I am very grateful for this wonderful team and, of course, to be led by Michelle. It's been such a great experience so far, and I look forward to working with all of you.
Thank you, Kate. And I think that rounds out everyone. Yes, good. So now you know all your council members. I'm going to pivot. Rob, I have this wonderful biography in front of me but I'm really looking forward to introducing you to Rob Egge. Rob Egge is someone that I got the pleasure and privilege to work with and for almost a decade. There is so much wonderful things, so I'm just going to share a few of the highlights that I'm particularly excited about. Rob is the Chief Public Policy Officer of the Alzheimer's Association and also the President of the Alzheimer's Impact Movement. Rob oversees government affairs, policy development, and grassroots advocacy teams working to secure policies to improve the lives of all those affected by dementia. He's led the association in achieving several major federal milestones, including the passage of the National Alzheimer's Project Act, or NAPA, and it's why we're all here today, which mandated the creation of the first national plan to fight Alzheimer's and a more than 7-fold increase in federal Alzheimer's and dementia research funding to $3.9 billion annually. In 2024, Congress renewed its bipartisan commitment to addressing Alzheimer's and other dementia by passing the NAPA Reauthorization Act and the Alzheimer's Accountability and Investment Act. We also did the Bold Infrastructure for Alzheimer's Act, so there's so much that Rob could talk about. But today, I'm very excited to hear from him. I got a sneak peek of his presentation about early detection, early diagnosis, and risk reduction. Without further ado, Mr. Rob Egge.
Chop that down a bit. Michelle, thank you, though. I appreciate all your kind comments. And it's great to be with so many people I had an opportunity to serve with on this advisory committee about 5 years ago. Just to start briefly with a personal note, like so many of you in those 5 years, this has become so much more personal to me and my wife in two very close ways. And I just thank you for your work. And one of the things that we noted about this experience as we watch this with family is how difficult it remains with the best intentions of everyone involved to have timely and accurate detection and diagnosis, and how that remains a central point. So what I'm going to talk about today, I think Helen can hold me accountable. I never said this when I was on the advisory council itself. This is the bill that I'm personally most excited to be working on with so many in the Alzheimer's community as we've all come together to support this initiative because of the role that I think that it can play, and I know others do too, and that's hinted at the analogy that you see in the title of the slide presentation. So I'll work through these slides and try to be somewhat quick about it, but make the key points here. And I'll first just get oriented to where I'm okay. So this became unexpectedly after choosing this topic and being focused on it just last week. And I don't pull out this quote for the broader context, but the specific point that the Secretary of HHS, Secretary Kennedy, last week called out Alzheimer's screening as something that was clearly on his mind in congressional testimony and the timeliness of this issue. That's not just and only the Secretary who has Alzheimer's screening on his mind. Congress does on a bipartisan basis, as we see in the context of the bill that I'll discuss, the Alzheimer's Screening and Prevention Act. The research community does, first and foremost, to make this a relevant conversation now through rapid developments. And then, as I mentioned, so many in the Alzheimer's community, too, as well. So, starting out with a historical analogy. 40 years ago, as many of us may remember quite well or have experienced, breast cancer was found too late. And at that point, there was a test that was validated, mammography, but for so many it was out of reach. And you can see this somewhat in the statistics here. 14%, that was the screening rate at that point in 1987, the first year that the stats were kept. The amount of the coverage, there was none, 0. The 600,000 refers to the fact that the community of those who wanted to do something more for those with breast cancer and believe they could. This is in a time when advocacy looked a little different, and you might even say felt more authentic. There's 600,000 letters were sent to Congress in 1 year alone in support of making mammography covered by Medicare. They succeeded, Congress acted, and Medicare became the first such covered service by an act of Congress giving the authority, not the requirement, but the authority to the administration to provide Medicare coverage. So as a result of that, I don't want to be too reductionistic. There's much, I'm sure, that was going on here that drive these facts. But by all accounts, central to what we see here of an increase in screening through mammography from 14% to 70%, and a drop in breast cancer deaths by 44%. By all accounts, this coverage was central to this story, among other factors. So the key points about this is that the coverage didn't just save lives. That's the most important thing, I think, to all of us, especially if you can think about this in personal terms, like I talked about with Alzheimer's at the start here, but also it drove systems change. And I won't belabor these points here, but along with this, a system came to recognize breast cancer in new ways, provide integrated ways to deal with it, and that was part of the story. So even where it wasn't mammography directly, it was also driving systems change that became so important. Now, my contention is that in some ways, in a way that's directly relevant to this story, we are living as Alzheimer's community in 1986. And I don't mean that necessarily in a depressing way, but in an opportunity way. I think we felt as we worked on Alzheimer's, there's been different times we've been a little bit later than some other chronic diseases to different milestones, but we're always so glad when we get there. And so now we have emerging, we can see where we stand now with Alzheimer's screening becoming for the first time a real possibility to implement because of the developments primarily in Alzheimer's blood tests. So are we ready for this next step? I'd absolutely say so. But let me first talk about this in terms of what we could describe as the problem that my family's experienced, and perhaps yours have too, and we can see it in other ways as well. So today's treatments that we have, the ones that are disease modifying, the two that have been approved by FDA and are accessible today, we know from the phase 3 clinical trials, and then we see this again in follow-on data, that they work most effectively, they work best in a window that most people miss. And so right now, 9 out of 10 people slip right through this early period that we refer to, of course, as mild cognitive impairment. So the 47% figure you see there refers to donanemab and what was reported out when you measure this in terms of tau accumulation. Those who were early in the disease process, it was 47% more effective in terms of the slowing of cognitive decline, this donanemab in this case. Very similar story with Kisunla. But the less than 10% refers to the amount of people by the studies that we've consulted that are actually identified and diagnosed within this first multi-year stretch of mild cognitive impairment when we know the treatments will be most effective. As a matter of fact, the two studies that have studied this most directly both agree through different methods, coincidentally on 8% is likely the rate that these studies concluded of diagnosis within MCI. So that's what I mean by we pass right through this moment of many years when, from this vantage point of these treatments would best be started, a missed opportunity. Now, I'll be talking about the science has arrived. I mean that in a specific case, not necessarily judgments that will need to be made if this legislation were to pass, which I'll describe in the future, about where does the evidence stand at this moment. But the evidence is accumulated to the point that this is the right time for Congress to be considering solutions and to work on them. And so here I'll simply say that we've seen impressive movement with blood tests in the context of those with a cognitive complaint, the context in which FDA has cleared 2 blood tests, one in primary care to rule out and the other in specialty care. And we see now, maybe not a daily drumbeat, but close to it in terms of new studies that are examining blood tests from different perspectives. And the evidence, due to robust funding, thanks to Congress, thanks to your leadership for the way it's been used well, is accumulating rapidly. And this last figure here is 91%. It refers to the amount in our own facts and figures last year. We just had our new release days ago, but last year's special report, 91% of Americans said that they would personally want to have available to them Alzheimer's blood tests. That's a pretty high number for Americans to agree on something. So we are now, there's one last point I wanted to highlight. I talked about treatment, but there's other benefits as well. I personally think one of the most profound benefits, which is maybe subtle for those who haven't lived through the experience of progressive dementia in a loved one or going through it themselves, is the fact of what a gift it is to be able to understand where you are earlier and being able to be a full participant in planning for your own future and having to say in what should unfold, including treatment, but many other things as well. This slide points to yet another example, and it was in a study that was published in Alzheimer's and Dementia, I believe just 2 weeks ago, based on work in the environs of Chicago. And it found for those that they spoke with and explained these blood tests to, strong support among those community, those individuals for blood tests, just like the 91% study result I described a second ago. But this 87% refers to those who, if they were to have a positive blood test, a result that indicated Alzheimer's, that they would take steps to live a healthier lifestyle. This is important because of the U.S. Pointer study, among many other studies that have shown and validated that the right recipe of lifestyle changes can be effective, as that study showed, in slowing cognitive decline. So again, it shows from the context of, for instance, the Secretary's own emphasis on healthy lifestyle, the role it can play, how these things can come together with screening. So now let me talk to you about the fact that fundamentally that what stands between us today and the possibility of Alzheimer's screening is primarily a legal issue. Unless there's another pathway through the U.S. Preventive Services Task Force. That task force just recently, as they developed their research program for their next look at cognitive impairment, declined to consider blood tests in that context, so they ruled that out. They'll probably come back around again in the length of their examination process, and then when they circle back in another 6 or 7 years. So that's one reason why I say that the primary path right now is legal. The only way to resolve it, given that timeline I just described, is through an act of Congress, just like we had with mammography and many other places where we have coverage for screening today. Congress has to act. When they do so, as I'll describe here, they do it in the form of legislation. We're very, very excited that the Congress, on a bipartisan basis, has introduced and is advancing the Alzheimer's Screening and Prevention Act. Those of us who work on this bill soon come to call it the ASAP Act, and the reference, of course, is intentional because we believe we need to move quickly on this opportunity. So this is already introduced in Congress, and what it does are two things. First of all, to get back to the point that you could say the evidence is still accumulating definitively on is it time now to have Alzheimer's screening and coverage for it. This legislation, like other bills similar to it, never mandate coverage. They don't say from Congress it is time for coverage. Instead, they give permission or authorization for the administration to determine through their evidence-based process whether or not it's time, and when it is time then to extend that coverage. ASAP does the exact same thing. What it does is it provides the authority, the permission for Congress, the Congress does for the administration to go through that process. Specifically, it would be CMS that would use its well-defined and tested evidence generation evaluation process to make a determination about when blood screening is appropriate. So Congress just passed such a bill also. If you just think about it, has Congress forgotten how to do this? Absolutely not. Just months ago, by coincidence, Congress passed the MCED bill, the Multi-Cancer Early Detection Act, which basically has the exact same mechanism in the case of blood screening for cancers. So let me just say a few more things. One more thing that I want to highlight and come back to is the fact that Alzheimer's and related conditions, we believe, would benefit very much from ASAP, not just in the case person by person of what it would mean to have the possibility of early screening so that, for instance, if they elect to and they decide it's right for them, they can have access to treatments when they are proven to be most effective. But there's also, just like in the case of breast cancer, which I described earlier, the systems impact of this to make what's so often invisible for long in health systems and other contexts visible, charted, coded, and have that same response to it. So I really appreciated when I served as a non-federal member and had more latitude on these things to consider. What we could recommend is members of the council. So I thought I'd do the same and point out a few things that jumped to our minds at the Alzheimer's Association. I think others would agree, and other organizations, about things that NAPA Advisory Council could consider, and it would be good to consider, that relate specifically to this opportunity. So 4 of them. First of all, for those of you new to the Advisory Council, you've probably had a lot of briefings on this. You have quite a range of things you can consider. One of them is simply to recommend the consideration to the administration of legislation. They can decide, of course, as they often do, although it's not that frequent, to this first point, to issue a statement of administration policy, a SAP, which is their way, one formal way of saying we support legislation that's moving through Congress. So that's one opportunity here in terms of things that are related to ASAP that would be relevant here in an administration context. The second is that we're very pleased that CMS, several years ago, Sherry, I don't have to go to you for the exact year now, but thanks for all the work that led to this, released a very important code, 99483, which provides for the possibility of care planning. That code was perfectly crafted, we think, by CMS to the moment we were in at that time. But we continue to see our space evolve as so much exciting work is happening in research and other contexts. There are 2 provisions to that code that come to mind in this now, the possibility of blood tests and earlier detection. One is the fact that it pegs it specifically, that code, to having cognitive impairment. A second one is that it requires the presence of an independent historian, to use that language, which is basically somebody else to sit alongside the person with cognitive impairment and be part of that care planning process. If you think about where we're heading, arguably where we are today, in cases, we will be able to detect and diagnose when, as I said earlier, the person with Alzheimer's in this case specifically absolutely has the ability to be fully engaged in their own in that care planning discussion, especially if we're talking about a context before symptoms, right, by definition. And so the fact that they would be required, even if we could, so 2 points here. First is to waive the requirement that it only be in the context of cognitive impairment, because care planning is as relevant and important before the onset of symptoms as afterwards. But second of all, it shouldn't be a requirement to have somebody present if you're fully capable of having this discussion and planning on your own, right? So those are 2 things as we just think to the future where we're heading that now are opportunities to make this care planning, which would take on a different tenor, but be absolutely as relevant in this context. Third, this is a very big issue, and I would not do anything to dismiss it. For many different diseases, we have concerns about, but maybe it's especially poignant in the case of dementia, about the protections that are needed with these biomarker results. That's a tough problem to solve. Congress typically isn't inclined to solve these disease by disease, but in a broader context, which takes more inertia and effort to get things done in a timely way. But one way back in 2000, the Clinton administration where they got a conversation started about genetic information non-discrimination, what became the law GINA in 2008. They got that ball rolling in an important way with an executive order that applied to basically federal employees. It did a few other things, but it extended to federal employees, and it provided what the protections basically of GINA in that early context for them, and started that conversation in that way. I can easily imagine and would recommend that that same consideration be given right now to protections in the context of biomarkers. An executive order be with the administration's purview to issue that for federal employees. And more details around that, but that's the essential idea. What worked in 2000 could be exactly the right next pragmatic step today. And then finally, wrapping up here about recommendations related to this topic is potential of a coverage pathway for those healthy lifestyles that I described earlier. We have, thanks to the working part of the NIA, this validation of that these lifestyle, we've tested a protocol, it works. We see that now in a rigorous phase 3 trial. That evidence is in. One opportunity is to provide a pathway that goes along with a positive indication, positive test result in the sense that you do have Alzheimer's, perhaps before symptoms, that pairs that with healthy lifestyles that we know work, those interventions to encourage and adopt, just like we see, for instance, in the context of diabetes today. So those are our 4 concrete recommendations that we think complement the work on to advance the Alzheimer's Screening Prevention Act very well. So here's where I want to just wrap up here on this. You know, the phrase that resonates to me the most, and it might be different ones to you on this, but is that we're finally ready to detect early and treat early. If you think about wrapping up, starting with that story of breast cancer, what is so intuitive to so many of us, because we experience in so many chronic diseases, is the goal is always how fast can we find out, then how fast can we start doing something about it. And for a long, long time, Alzheimer's, other dementias still, sadly, in the case of other dementias that are lagging behind this Alzheimer's story, and why I've said Alzheimer's so many times in this conversation. For us, it's been a long time of watching that, watching the evidence accumulate, wishing we could be there. The exciting thing is that I think we're there. We are there at the point where we can now see ways to detect early, especially in the context now of mild cognitive impairment before it's been recognized by a clinician. And we have seen that we are now at that point of treating early, not just in a symptoms case as we have for years, but now in disease-modifying terms. So bringing those two things together is the opportunity we have. And I do think, just like 40 years ago, this stands out as a generational opportunity that we really can't afford to delay. So with that, thank you very much. Appreciate it.
I was going to see if we had some questions for Rob. I hope we do.
Thank you, Chair. Rob, or you go by, is it Robert or Rob?
Rob.
Okay,
correct.
I'm following
Either
her
way,
lead.
though.
So 4 recommendations. Who has the Alzheimer's Association made these recommendations to before we just looked at them? Have they been presented to anybody before us?
You will not be the last, but I think you might be the first.
Okay.
Yes.
Okay, curious about that. Thank you. And can you pull Secretary Kennedy's quote back up? I think it was your very first slide.
Yeah, I can. Maybe somebody else will get me there faster, but I'm going pretty fast here, so don't. Ooh, very fast. All right, this is it. This is what you see, the ellipses, meaning preserved, but yes.
So being a military guy, was, am, and will be, that's commander's intent. That's our end state right there. We are not going to continue malpractice. I'm just reading his quote, because this is what our clinical care committee talked about today, this very thing, similar to what your 4 recommendations are things we specifically talked about, all 4 of those. So appreciate you bringing this up in our attention. What I didn't know was that Secretary Kennedy said that, and that helps. Thank you.
You bet.
Thanks, Rob. So I was struck by having to go to Congress for mammograms and again for Alzheimer's disease. Have you all considered suggesting that drafters broaden the language to include related dementias, so that
I'm sorry that I did not bring that proactively. So it is broad.
Okay, great.
To include, but I'm glad you pulled that out of me,
Yeah.
because that's very important to us.
Yeah, and then you don't have to go back again. And then my second question, and this is also to clinicians in the room, is does the clinical workforce in the U.S. have the knowledge that they need to get this information about their patients and to know what to do with it and what it means to have the pathology of Alzheimer's disease but not have any symptoms? Because that will happen.
Right. I'll start, but there's better expertise in this around that table, so I'll just add this point to start that conversation, which is that among other ways to consider that question is the fact that implementation takes time. And so I mentioned that cancer analog, not breast cancer, but MCED, that bill, that was passed in February. Its date of enactment is 2028. If ASAP were to pass this year, which is our fervent goal, it at the soonest you could imagine would be 2028, but more likely 2029, as soon as possible, of course. But that one of those things that would be important to do in that interim is to provide that training, because today the answer would be no, in my experience.
Go ahead, Steve.
Thanks for that presentation. I've had the chance to reach out to my congressman on that bill and to support it. I wonder what our timeline is for us doing something to support it.
Timeline? I think the timeline for the advisory council to support this sooner is better, but I say that understanding that you have lots of things to weigh that I don't have in my head right now about that constrain your timeline. But I can set that aside and just say that the sooner that these steps would be taken, I think they would all, as I think through them, each of them, it makes sense immediately of those 4 recommendations.
So before July?
If it were possible, I'm not sure it is, but yes.
Oh,
yeah.
Can always ask.
Yes.
Thank you.
Thank you, Steve.
Any other questions?
Yes. I just want to commend you for this, Rob. This is extremely inspiring. I urge everybody in this community to get behind this, because awareness is the beginning of the cure. You need to know that you have a problem ahead of you. In many of the state diseases that we face, yes, we don't have great treatments today, but they are coming. And as you said, we do have ways to change life. So you see somebody that has a brain aneurysm and learn that cigarettes have a relationship with that and quit smoking because of that. So even though on the treatment side, medication, surgeries, we're just starting, thankfully, and going in the direction of curing this terrible disease, learning that you have that can change your life. It can slow the disease process. So I think Mrs. Chairman or Chairwoman, I don't know what is the proper term these days, I think we need to get this all over our recommendations. Again, thank you for putting this together. I love the analogy, and you can count on this little guy here to support that wholeheartedly.
Thank you so much. I appreciate that.
Hi, Rob, and thank you so much for all of the work in the presentation. So I have a couple of clarifying questions for you. So one, just acknowledge the importance of identifying cognitive impairment, right? Yes. So we get hung up for good reason on the term screening. Is there opportunity to also think about how might symptoms be detected that may or may not lead to a diagnosis of Alzheimer's disease, but at the point of care and as care proceeds, it does matter knowing if a individual needs additional help with understanding the treatment options, the care options, and all of that. So, as you are doing your work, sometimes when the work comes to us at HHS, we are tasked to implement. We also welcome the opportunity when it has that little language that says and as otherwise determined by the secretary, because sometimes otherwise we miss an opportunity because it's overly prescriptive, and it gives us little latitude to really apply what it is that we know in the scoping of even as something as simple as a code. We've been looking at the uptake of the codes as they are, but have great interest in broadening the opportunity to trigger a discussion between clinician and the person before them, we call them patients sometimes, and bring them into the conversation about what care goals are, what treatment options are. So just to say, some of that work is underway, but it does not have the label of Alzheimer's, or it is about care planning. Mm-hmm. So I think, at any time we'd be happy to provide an update of what we've been working on as far as care planning and how to breathe life into that. I did miss this morning's workshop because to reflect on the question that was asked about that Helen raised, is the workforce out there, are they ready? And so HRSA had a geriatric workforce education program where they're trying to bring up the floor of care providers out there who actually would be working on age-friendly. That includes better detection and better diagnosis of issues with mentation. It's one of the 4 M's. So just building on what this conversation represents and what, CMS and federal partners might be able to contribute over. Thank you.
Thank you. Just a comment on your comments, which I really appreciate and agree with, that I didn't define the term screening as it's used in this context, and I should. So screening refers to specifically diagnostics when there are no symptoms present or not detected. So it's in the absence of symptoms. So where this would work, for instance, in part, is that you can imagine with today's context of treatments, that if you had a positive result, you did not have symptoms, you would not be able to start that treatment, given the FDA label, until symptoms emerged. So it would lead to a cycle of heightened vigilance, maybe a lifestyle changes, planning, and also vigilance on the emergence of symptoms. And I would suppose you'd be in a conversation that would detect those earliest subtle symptoms that often are missed for years, when you could move with your healthcare provider into a context of treatment. And all the aspects of planning that you talked about are really appreciated, Sherry. Thank you.
Thank you so much, Rob. We really appreciate it. For any of us that have any future questions, just let me, Helen, or Maria know, and we'll get those to Rob. Okay, I had to give Rob a quick hug there. I hadn't seen him in a while. Okay, I also wanted to just introduce a fearless leader from ACL. Mary Lazare just joined us. Hi, Mary. Thank you so much for being here. I wanted to just take a minute. We're going to transition because we have a very full agenda, folks, full of a lot of amazing different viewpoints and looks into Alzheimer's research, care, and services. So today we're focusing a lot on care. So it's my pleasure I'm going to talk to you a little bit about her bio. Dr. Rosemary Laird is somebody that I've had the opportunity to work with for, over a decade. She's an outstanding human being, and if I had to refer any of my loved ones, they would be going to Dr. Rosemary Laird. I just think the absolute world of her. She is a clinical associate professor in the Department of Geriatrics at the Florida State University School of Medicine. She serves as a principal investigator for ClinCloud Research in Vieira, Florida, and she is the founder of the family caregiver support company, Navigating Aging Needs, LLC. Dr. Laird received her medical degree with honors from Georgetown University's School of Medicine in 1991 and completed her internal medicine residency and geriatric fellowship. She is a recognized expert in diagnosing and caring for patients with Alzheimer's disease and has spent 20 years as the medical director for 2 state-designated memory disorder clinics. In 2019, the governor of Florida appointed her to serve on the State Alzheimer's Disease Advisory Committee. She is a sought-after speaker, educator, and was named the American Geriatric Society's Geriatrician of the Year in 2013. And that is just her resume, folks. I haven't even begun to speak of her heart. So thank you so much for joining us, Dr. Rosemary Laird.
Secretary Branham, thank you so much. I really appreciate that. And good afternoon, everyone. I wrote about a week or so ago my opening line, and I was going to say this is an extraordinary moment in dementia care. And as I was sitting here, just the last, hour and a half, I had no idea how extraordinary a time this is. The work ahead of us and the work of this group is really inspiring, and I'm very proud and honored to be here. And it is an extraordinary time. As a clinician and researcher, it's an extraordinary time to be in among the various advances in the science that we are working around today. And just the whole discussion about screening and treatment really gets my wheels rolling. But I'm very appreciative of the Secretary inviting me here for this specific topic. And she helped pivot us to care, because that is really my excitement right now about this issue, is that every day in clinic I see some of the 7 million people who are already diagnosed and living with this illness. And I also see the many family members and friends who come with them often to help care for them as well. And it's that group of people, the family caregivers, that I'm here really to talk about today, because what I have learned since early in my career, I was fortunate to learn this lesson early, is that when you care for individuals with these types of illnesses, family caregivers and friends, when I say that term, just think of a family member or a friend, become really involved in ways that we don't imagine when we first think about someone helping someone else. This illness requires that gradually and at some point, for most of my patients with dementia, they will need someone to help them make appointments, manage medications, make decisions about a symptom and whether it should lead to the emergency room or an urgent care or a call to the doctor. Yet across healthcare, these caregivers are largely disconnected from healthcare, the healthcare system writ large, and unsupported in most cases. At Navigator, we really want to be part of the transformation of the healthcare system. We really believe that that transformation must come, and it really needs to include 2 key factors. We want to continue the work that has started to bring those caregivers closer into the nexus of care for our loved ones in collaborative dementia care models. And we also believe that we must create a workforce, an effective care navigator workforce that is alongside of these caregivers to make that impossible responsibility of caregiving possible, just a little more possible. So first, I know oddly, I'm going to now thank people. But again, thank you to NAPA for the invitation to be here. It really is an honor to be standing among all of you. And I know that the work here today is the culmination of years of probably many of our colleagues and people who went before us. So we know we're standing on the shoulders, and we really appreciate being here. So thank you. I am Dr. Rosemary Laird, and it's an honor that I've spent my time as a geriatrician primarily as a memory care specialist. My husband always jokes, "What, you don't care about the aging of the rest of the body?" But certainly I do, and it has been an important journey for me, and I'm fortunate that I've found my co-founder, Patty Allman, along the way, because with my clinical perspective, Patty brings her caregiver perspective. And together, we recognize something fundamental about the situation we are trying to address, and that is that family caregivers are doing some of the most important work for our loved ones with dementia, but they are doing it alone and disconnected. Our mission really grew out of that, and it started when I realized when I first started practicing. You know, you leave medical school and you're very well schooled in the patient or in the doctor-patient relationship. That you walk in a room and that's what you expect to be the focus of your attention. And as I started to take care of more people with memory cognitive complaints and eventually diagnosing them and caring for them with Alzheimer's disease, I started to realize I needed to shift my gaze. There was another person in the room. And in fact, there was another person in the life of my patient. So I had to expand my understanding that that spouse, that adult child, that friend, and in several very memorable cases, ex-wives had even stepped up to take care of someone who was facing this terrible illness. And that really grabs your attention when I realized as a physician that if I wanted to make a therapeutic connection and make some change in the course of this person's illness, I had to make sure I understood that the person helping them was the caregiver. The caregiver was my operational control center. If I wanted to diagnose something, if I wanted to prescribe something, if I wanted to know did that medicine work better than that medicine, it all had to go through my caregivers. And yet, there they were, being expected to manage something extraordinarily complex, medical issues, emotional issues, financial issues, legal issues, without support, without guidance, without structure. So that's why we built NAN. We are now dedicated and focused on becoming a service that can support care navigation to become part of collaborative dementia care models in the future. We first implemented NAN as a partnership with a wonderful area agency on aging in Broward County, Florida. Most of the caregivers there were supporting frail and high-risk individuals living with dementia. When those caregivers were partnered with our navigators, something somewhat predictable happened. Their caregiver burden rates went down. But then we also noticed something that wasn't as predictable. Caregivers reported dramatic reductions in falls and hospitalizations amongst their loved ones. That suggested something to us. Was it possible that the support of the navigators helping the caregivers, they were actually then able to better influence their loved ones' health outcomes? These findings were eventually published or were later published in Alzheimer's and Dementia, and really began our quest to looking at the full capacity and potential of that therapeutic alliance when we bring caregivers into the care of people with these illnesses. We're now working to expand the understanding of the potential of that relationship. We believe there's potential that working with providers, we can help them see benefit from improved care and reduced administrative stresses on their clinic teams. We also believe there's potential for payers to see reduced utilization and cost, as well as improved satisfaction with care. That's our future. That's what we're working towards now. I want to step back and give you a sense of how NAN really works. So what's it like for a caregiver? Well, first of all, they get assigned a personalized navigator. So one-on-one, that's your navigator, that's who's going to be with you through this journey. Over time, they develop a relationship. Typically, and at least monthly, they're in some kind of contact. It might be a phone call. Some people like text. Some people like email. It really is up to the caregiver. Our navigators can work in all those formats, and they do so because caregivers themselves work in all those formats. And it's really up to the caregiver. Outside the monthly touch points, caregivers are allowed to call anytime they need to, anytime something arises. Behind that relationship that becomes so important, caregivers actually tell us that they really appreciate only having to tell their story once. They don't repeat it every time they go to get some more advice. And behind that, I'm going to focus right here for a minute. Behind that, or really under that, is a technological support platform that focuses on making our navigators the most efficient and capable they can be in helping people through a condition like this. The structured platform includes a risk assessment that helps our navigators identify early and in a comprehensive way risk the caregiver may not even realize exists. Things like falls, caregiver stress, safety risks, financial strain, or lack of support systems, things that may or may not be causing trouble now, but may likely cause trouble in their future. The platform helps navigators generate personalized recommendation for education, maybe caregiving strategies, community resources that are specific to that specific risk that was identified. An example, if falls are identified, the navigator may help the caregiver think through, what can I do at the home to improve safety? Do I need any mobility supports for my loved one or to help them move? Do I need to have any conversations with physicians, or did I misunderstand what the physical therapist said? Are there other additional services that I could think about that I as a caregiver wouldn't have thought about that could help reduce the risk? All of that goes into a plan when we identify those risks. Now, the last part I have up here on the screen, arguably, I can't decide which of these is the most important feature. This may be it. The navigators and caregivers review about every 3 months the risk assessment that I was talking about. It sets up this terrific ongoing cycle of risk assessment, risk reduction, and accountability, checking in on how we're doing with that risk reduction. It's a terrific and kind of ongoing continuous quality improvement loop that the caregiver can let out of their mind while they're busy doing other things, but our navigators pay attention to it and keep track of it. We believe that's a real asset to our system and how we help really motivate and achieve change for these caregivers who are undeniably stretched thin in most instances. So that model is what we've now taken forward and used throughout Florida in a few different ways. We're immensely grateful and appreciative of the partnership that started our journey with NAN, with the Department of Elder Affairs. And this initial slide shows the work I referenced earlier. And we continue now working with the department to further our understanding of what aspects of that model work, how it works best, and ways that we can make it work for more people, increase the capacity of it, as well as find ways to work in understanding different aspects of the model. As I mentioned, utilization, healthcare utilization, and information on claims data to help balance out the information we have now, which is the caregivers reporting their results and their incidences of falls and hospitalizations. So to dive a little bit more specifically into the trial or into the program where we've advanced from our early days, we now are very fortunate that spread all across Florida from the Florida Alzheimer's Center of Excellence program are multiple navigators who are now using the NAN software. And together, FACE, powered by NAN, is now serving upward hundreds of caregivers over the course of every day and helping them through this program. Of the 34 caregivers who have completed the first wave, who've completed 12 months of support, you can see that they've reported similar consistent trends to what we saw before as far as reductions in hospitalizations, reductions in falls of similar magnitude, and lower caregiver stress, which we are always happy to see. And one additional factor was evaluated with this group, thanks to the input of our partners at the Department of Elder Affairs, and that was the Net Promoter Score. You may be familiar with that score, asking people how satisfied they are via the question, given your satisfaction with this program, are you satisfied enough to tell someone else to do it? And for a busy caregiver, we think it's high praise indeed that there's a perfect score of, yes, we would recommend FACE navigation to other caregivers facing this kind of challenge. In addition to, I mentioned the second of the programs we're now doing with the department, and this is really again, it's an opportunity for us to study in a bit more rigorous way the model. We've partnered with Humana Florida, and with them, with 34 primary care clinics in an affiliated primary care group called Conviva across Florida. And this effort is really so that we can look at real world data. And we've undertaken a randomized controlled quality improvement study examining hospitalizations, and that is the study that will be using claims data. Now, while claims data are still forthcoming in the coming months, actually, early caregiver reports that you see on the screen are here, and interestingly, they are consistent with our earlier findings. Again, reductions in hospitalizations and falls of a similar magnitude. Again, burden of our caregivers is being reduced, and the satisfaction with the program is similar. And that's really the core of what we're doing, is trying to relieve stress and bring caregivers to a place where they can feel more confident and comfortable with what they're doing. Nothing is worse than a caregiver sitting across from you and saying, I just don't know what to do. That feeling of helplessness when you're across from a loved one is an emotion we always try to address. And one of the people I wanted to talk with you, or share with you really, is one of our caregivers named Vera. So Vera is caring for her mother, Angelique. And when we first met Vera, she was overwhelmed, to say the least. So the main issue that she mentioned first was that her mother was eating poorly, growing weaker, and just about every day was falling as she was getting out of bed in the morning, because Vera had to leave for work, so there wasn't quite 24/7 coverage at this particular time. Our navigator, hearing that and having done the assessment, helped identify resources to address her poor nutrition and weakness, as well as realize that there had been a lapse in her communication with the Area Agency on Aging. So in collaboration with the local area agency, they were able to identify an advancement in her illness, and she had now qualified for an increased amount of in-home support, just enough to cover those morning hours and evening hours before the family was able to be there. But what was also identified in the assessment was that Vera had significant financial concerns about her ability to continue being a caregiver with her mother in the home. She had no backup caregiving plan. She had almost gripping fear that if something happened to her, what would happen to her mother. Our navigator investigated further. Backup caregiving plans are big for our navigators. They know that's one of the first things we encourage them to work on with caregivers. And in Vera's case, they helped her have some conversations that ultimately resulted in several family members, some out of state, but several family members stepping up, both financially and some who were local, helping with actual physical care coverage for Vera. In combination with this, the falls reduced, the hospitalizations reduced, Vera's caregiver burden reduced. Her mother is still in the home, being cared for by a much bigger network of family members, but in the home. Now that, I think that shows the complexities of care. You can't just, try to make someone not fall. You have to understand all the myriad reasons, all the constellation of challenges that these caregivers face. And that's really why we think our process of having navigators who are provided with a system that allows them to be comprehensive and proactive and pay attention to the problems that people are facing over time, that really helps them be a very effective form of support. And the caregivers do tell us that they appreciate it. As you heard, the Net Promoter Scores. A couple of just quotes from other people that I think capture it well. One of them said, "You made a huge difference at a confusing and challenging time in my life." We hear the word confusing a lot, and I know that's not going to surprise anyone. And the second one really hits at this whole issue, and that is this caregiver thanked us and said that their navigator understood that dementia excuse me, affects not only the patient but the whole family. I think for caregivers to be seen as somebody who is impacted by this illness goes a long way to helping them feel like they have a chance at making the difference they want to make, and that they feel recognized and supported for that. So we're certainly gratified to hear those comments, and we're very blessed because they come in frequently. We're very blessed at NAN to have those. But we also understand that from all these efforts, it's only the beginning. Just like many of you, we're still aware that we have many more paths to take to make this kind of care, as our mission statement says, available to every caregiver. We know that caregivers influence care of their loved one in powerful and significant ways. But they cannot do it alone, and they should not be as disconnected as they are from the healthcare system. We are certainly in a new era of dementia care. But even the best therapies will fall short if families are left unsupported. I can send a patient for Kisunla or Leqembi, but if someone doesn't answer the phone, this literally happened last week, but if someone doesn't answer the phone at the office and help a wife know what to do when the husband was abruptly fired and had the police called on him because of a problem he had driving a company vehicle, that is an example of how we must be able to do and give caregivers a place to call. She literally was able to call the navigator and be able to have that situation. Can you imagine that situation on a Thursday afternoon coming up? That's the kind of care support I really dream of that every caregiver facing this illness could have. But if we want those outcomes, it has to be that our work has to include more than the medications. We need to integrate caregivers into collaborative dementia care models and build an effective care navigator workforce. Thank you.
Thank you so much, Dr. Laird. We're going to hold questions just because we're at time. So for all the speakers, Maria has put a nice little bulk of time right at the bottom, too, so we can ask some questions in just a little bit. So thank you so much, Dr. Laird. Next, and then I promise I'm going to give y'all a break at some point. I promise. But we've got so many great speakers, so I don't want to hold up anything. I'd like to introduce you to Daphne Johnson. I had the privilege of meeting her at a conference and then again invited her to speak several times in Florida. She is a nationally recognized advocate for families living with Alzheimer's and dementia and the founder and executive director of the Respite for All Foundation. And that's a nonprofit dedicated to expanding innovative, volunteer-based respite care across the country. With a background in gerontology and more than 15 years of experience in senior living administration, Johnston launched the original Respite Ministry in 2012 at First United Methodist Church in Montgomery, Alabama, creating a faith-based model that provides meaningful social engagement for individuals with memory loss while offering critical relief for caregivers. And I love her approach because it's so community-driven and faith-based driven. Her approach centers on purpose-driven activities, community involvement, and volunteer support, and has grown from a small little local program into a nationally replicated model, inspiring dozens of respite communities across multiple states and earning recognition from organizations such as the U.S. Administration on Aging. She's a speaker and author of Reclaiming Joy Together and continues to advance the scalable, community-based solution to one of the most pressing challenges in aging and dementia care in our nation. Please join me in welcoming Daphne Johnston.
Thank you so much. You know, she invited me to Florida, and I go down there with all these serious, smart people. I get up to present, and my slides were the ones that took off. Carrie Ann and I were talking, and I had to make do. I hope that doesn't happen today, but a man came up to me and said, "You were Dolly Parton up there." So I hope I can wake you up before our break. I just want to start with my mother was a 42-year county agent with the Home Economics Association. County agent, right? She was lifting people out of poverty, she and her colleagues. I know that those innate abilities from the gatherings and the conferences that I attended as a childhood thing with her, those are in me now, and they're in our network, because Alzheimer's and dementia needs a national network, just like Extension Service, right? So we can collaborate and share the best ideas, and that's what I hope to accomplish today, sharing something important that we can have in all of our counties, all of our states. And I hope you all hear this message and think, how am I going to help that girl? How am I going to help her get this in my state, right? So as she said, we started in Montgomery, Alabama. I'm just going to play a 3-minute clip. We had a documentary made 2 years ago, almost 2 years ago now. It's already aired on Alabama Public Television. It's been sent to PBS affiliates. It's been viewed almost 6,000 times on YouTube, and we have not done one marketing campaign. This is a grassroots movement that I hope you'll take part in. So let's see if it plays. Oh, right. The vision for the Respite Ministry began in 2012.
We started asking the question, what needs to happen in this community that will not happen unless a church does it? The one that seemed to match our church best was something for people living with dementia and their families.
90% of the needs expressed by families facing dementia fall outside the domain of medicine and tests, but rather in the how-tos, how to provide care, how to improve well-being, how to sustain quality of life within the family.
What we landed on was we were going to begin this awesome volunteer ministry that would serve the community.
We play games, we laugh, we joke, we just do it all.
These programs are filled with happiness and genuineness. It's just a beautiful thing to see.
Because we're volunteer run, we can have a 1-to-1 ratio, which means there's no othering, there's no teacher-student, there's no somebody who needs to be taken care of. You get to show up as yourself and be part of the crowd.
That's very unique and it's very important.
When I go down into the room, I really cannot tell who is the friend or who is the volunteer. It just provides that safe environment that they can be themselves there.
Senior adults don't merely want to be entertained. They want to be needed, they want to be useful, and so respite care is ideal for really any age or circumstance.
We incorporate service projects in our daily planning. Packing surprise bags for cancer patients with like chocolate and water and chapsticks and such. One program in Dothan, Alabama packs diaper bags for young mothers. It's making a difference in our community, right? How do we set them up to succeed, and how do we set them up to give back?
To be needed, to be valued, to have others recognize your dignity as a person, no matter where you are in your life. That's a beautiful thing, and people want to be a part of that.
It's the day of the week that I laugh the most, I get the most hugs, and it's a family.
Do you know how hard it is to make a new friend after you've had a diagnosis of Alzheimer's or dementia? But in our ministry, you're meeting multiple people through the week who care about you, who miss you, who look for you, who need your presence.
It has blurred the line between who is the care recipient and who is the caregiver.
It's going to change the world. It's a model that any church can do.
Our goal is to reclaim joy together and to live on in this friendship revolution that we've created.
This is one of the most magical, transformational things you will ever attempt to do.
This is a ministry from the heart of God, and God is waiting on you.
If you have a parent or a sibling who has dementia, this might be something you would champion.
We are just beginning. So you can find that on our website at respiteforall.org or YouTube. But what a tool that we've got now that explains that this is not a babysitting service. We have figured out how to have a community model of respite that people want to be at. Our biggest problem was we have to cut volunteers back. Have you ever heard of that? We have to schedule them in a timely manner because they all want to be there. So from our ministry in Montgomery, people began coming to figure out what we were doing. We thought we were going to build a $2 or $3 million Alzheimer's center. We were going to be state-of-the-art. But what we realized was we needed to replicate our model because there's over 4,000 churches across the country with empty space in the middle of the week. We have got churches with empty space that can host these free communities with no overhead, often pay for a lot of the expenses, and have ready-made volunteers ready to go. It's just a model that's is really remarkable. So we started one in Montgomery, and now 13 years later, you can see we are in 19 states. I think we're at 72 and counting. And by the end of this year, of this calendar year, we expect 90 respite communities. In 12 denominations, we've got 2 or 3 planted in senior centers, our all-star senior centers in Chapel Hill, North Carolina. I'll be presenting at U.S. Aging. It's places where we've got free space and dedicated volunteers that can offer this community model, right? This is better than something in a bottle to me because it's immediate. We are in research trials. I'm listening to all of you. It's going to take time, right? Everything takes time. But I'm telling you, families can walk in the door of one of our communities and be changed immediately. We are an immediate response to Alzheimer's. This is the most important slide I'm going to share with you, okay? What it is, y'all are going to know it, and then y'all are going to help me spread it. So it's 4 hours of respite care from 10 to 2. Caregivers can drop their loved ones off, go run errands, go to the doctor themselves. I had one lady that came back, and I said, "Did you go to lunch? What did you do?" And she said, "Oh, dear one, I went home. I was with my thoughts for the first time by myself in my house for 3 years. I was alone with my thoughts." That's what this program has afforded me, right? So it's 4 hours break for the care partner, but it's 4 hours of engagement for the person with Alzheimer's. It's a social model. I know you guys love regs and just deep red tape, but let me tell you, I got something so simplistic. There's 7 million people living with Alzheimer's and some form of dementia, right? 3/4 of them need medical care, don't need medical care. They need community. They need connection, and that's what we provide in a social model. That means we don't need a nurse. We don't need a retired medical director. We don't need insurance on medical policies. We are there combating loneliness. We are there combating isolation. It is neighbor helping neighbor. And we've got a system. We've got a system to replicate how we do it. So we offer a lot of training on the front end of starting these programs. You know, there's a lot of money out there right now for respite in a lot of different programs, but one of the ones I was looking at, they were offered like $200,000 to start a respite program. I won't name who, but it was amazing to me that they thought a program was going to get up and going in 30 days. It's just a sustainable program to me is very difficult to do like that. We do training on the front end to help the churches, to help the clergy, to help the vision team see that we've got to put a budget package together for the first year, for the second year, for the third year. We celebrate a 92% sustainability rate. That's unheard of. After 13 years of trying to replicate this, our programs do not close, and it's because of the training on the front end. It takes 6 months to almost 2 years to get these programs up. It really takes a community champion to hear what I'm saying, to go back to their church and think, "God, I can do that. Our church can do that. My senior center can do that." And then the process begins. We've got a small staff of 3 to 5 people. We're growing every day. But because we're a social model, it's easy to replicate. So we've got a high volunteer volume. As I've said, it's almost 1-to-1. That's unheard of. You look in the room, you see 15 to 20 participants, you see 15 to 20 volunteers, and the magic of it is you don't know who's who because we're all living with something. We've just got a different take on it, right? We're all in it together, and people want to be a part of it. Everyone does everything in our model. So volunteers are in there doing ball games. They're in there doing service projects. They're in there doing dishes. There's only one paid part-time staff member in this whole system. If Jacksonville, Florida were to start at the Episcopal Church that Carrie attends, they would have one part-time person, and Respite for All is going to train that person. The clergy doesn't do it. Nobody else does it. We do. For a minimal fee, $650 is our toolkit. But after that, it doesn't cost anything to be a part of our network and ongoing support. We don't need huge government grants at the beginning to get going. We need local aging consortium grants of $5,000 to $10,000 to $15,000. Once we get these programs up and going and prove we're sustainable, it'd be great to have some tuition dollars. We do charge $40 to $50 for 4 hours of care, right? That helps offset the cost. That's what makes churches want to take these programs on, because it's not just a black hole of expenses. We have shared responsibility, right? The beauty of it is no one is turned away. There's no financial paperwork that digs into people's Social Security. If Bob tells me that his mother is living on $650 worth of Social Security a month like my grandmother, then Bob's mother is going to come to our program. We will find a way. If they qualify physically, we will find a way, and they're not turned away. It's just the right thing to do, right? I get really excited and talk fast, so sorry. The launch of the programs, like I said, in our model, Respite for All, we train the local programs on the upside, on the beginning, and it's not a pilot anymore. I need you all to know this has been going 13 years. We have evolved and evolved and evolved. Aaron put me on a podcast probably, a little over 11 years ago, and we took off. We went to New York, we're in California, Kansas, down to Florida. It's just been an amazing ride, right? 13 years of a proven model. Also, the beauty of the program is, like I said, when you look in the room and you can't tell who's who, all of our name tags are the same. And I want you to think about your mother. I want you to think about your father. And some of you in here might think about your daughter. I've had many families come through where early 80s, late 80 family members are taking care of early onset 50 and 60-year-old children, right? Think of that family member who's in danger in your circle. And where do they want to be? Do they want to be in a babysitting service with volunteers wearing green smocks? Or do they want to be in a group talking like 8th grade boys in a locker room, telling jokes all day, doing service projects, helping their community? Where do they want to be? And do they want to have a red label across their face that says, hey, I've got Alzheimer's. How about you? No, we have figured out that we're all in it together. That's a part of the model. You can't tell who's who because we're all living with something. So why are we sustainable in these local programs? There's no overhead, one part-time paid person, social program, it's not medical. If the easiest way, I've had directors say, do we need to go do home interviews and assessments? And I say, no, you tell them what we offer. We're a social program, and then you invite them to the program for the day and, invite them to lunch. They're going to see if their person is able to be in this program. That's how we don't have to spend 20 hours on assessments, right? They've got to be able to use the restroom on their own, eat on their own, be a part of a group activity, and not need medical care through the day. Again, it's isolation and loneliness we're combating. We collect revenue from the daily fees. $40 a day is $10 an hour with a hot lunch. It's pretty good stuff. Insurance is covered by the local church. We teach the directors how to get community partners. And then, again, this is the simplest model out there. It's very easy to replicate. I want to play this short clip. This is Dr. Al Power, one of my favorite heroes in dementia. He's a big believer in the less drugs, the better, right? I cornered him at a conference we were speaking at in Canada, and I made him tell why he thinks our model's going to fly. Okay, so I'm with rock star Dr. Al Power in Canada, and I'm just going to ask, why do you think the faith-based volunteer model, Respite for All, is going to spread all over the world?
I think there's a few reasons why it's a really important model. First of all, being faith-based, it's a strong community. It's a community with history, with traditions. It's something that will bind people living with dementia in ways that makeshift groups that maybe aren't long-standing will do. So I think that's really important. Another thing is it connects the community through volunteerism. So once again, it's not just professionals. It is the community being connected. And the reason that's really important is because when you look at demographics, we're getting to the point where people with dementia can't simply be moved to care homes to be taken care of. There are not enough professional staff to just put people in long-term care, with or without dementia, as the baby boomers get older. We need to find solutions that keep people successfully in the community as long as possible. And this is one way to provide both meaningful engagement for the person living with dementia, to provide respite and support for the person who is their primary care partner. And I think it is one of the things that we have to do. We cannot professionalize dementia support anymore.
Wow, did y'all hear that? So another part of what makes our model so addictive is our large group members, our large groups, our energy. And I'm telling you, there's a difference when you walk in a room, when you come in a room with, say, 3 participants and 3 volunteers. It's very hard to grow a program with energy like that for 4 hours. And so in our model, we need 10 volunteers on that opening day with the first 2 participants living with dementia. We got to have a party, right? We've got to have energy. We've got to have people to participate in all the activities that we do. It's a key difference because when somebody comes to visit for the day and it's really, a sad little group of energy sitting around, piddling around a table, I don't know what they're doing, but they're not doing what we're doing. Or you walk into a room with 15 or 20 people throwing axes across the room and doing whiteboard conversations, and we've had a few wet t-shirt contests. I won't get into that. But it's large groups that make a difference, that make people want to come back. We've partnered with Dr. Fayron Epps. Many of you might know her as the leader of the Altar program. She's helping us open doors in African-American churches every day, and I just so appreciate her mentorship. This is just a slide that we give at the beginning of the training. If any of you thought, man, I could take this back to Texas, I could take this to New Mexico, we're going to get on a vision team call with our resource director. And your local church or synagogue or senior center would get on with our resource director, and we would walk them through. Let's think about your space. Let's think about your funding and your costs. Let's think about your insurance coverage. Let's think about the plan of operations. And then, most importantly, we want to train that local director with a marketing plan. It seems like a lot, but when they don't have to create all that, we have that in a model, it can be done. And we've proven it. It's been done 72 times, right? I want to grow this thing to 1,000 across the country. This is our ongoing support. There's so many one-off programs that are super. They might be great in Lexington, Kentucky. They might be great in Jackson, Mississippi. But we want to be great in every state. We want every one of our programs to be so stellar that when you walk in, they're going to replicate through their state, right? Other people are going to drive to see what they're doing. And so we have to offer support for that. So we have monthly calls where directors can log on, learn about grant writing, learn about marketing, learn about activity programming. They have it all given to them. It doesn't cost anything. We have an annual training where the directors and the leaders, volunteer leaders come. We had 220 people come to Birmingham, Alabama from 18 states just this past month. And then we have one-on-one coaching. We teach local directors how not to just depend on one grant that could possibly disappear. We teach them how to be a host organization, how to partner with civic organizations like Rotary and Kiwanis, how to go to family businesses, how to work with the aging consortiums. People will do these things if you train them. It's got to be in the model. It's got to be able to be replicated, right? I'm excited to announce that we're in our first academic research with Georgia State University. They've got an excellent gerontology program. They're doing our academic research as we speak. We've just launched this month, and we'll go network-wide in July, so I'll be excited about those results. And I'm close to the end because I know we all need to stand and stretch, but I do want to highlight some of our most important moments over the past couple of years, we were highlighted by Kiplingers. I mean, what in the world, right? As a qualitative alternative to long-term care. Alzheimer's Foundation of America named us the most innovative dementia program in the country, the Brodsky Award in 21. AARP included us in their national respite catalog this past year. We are growing. So one of the last slides, what does it mean to be a respite community, let's say in the state of Tennessee or the state of Kansas, and be a part of the Respite for All network? How we get these churches to be involved is we say, hey, you church in Wisconsin, you are not legally tied to a church in Florida. You are not legally tied to a mothership. We are a model that wants to help you replicate, and you run your own local program and you be responsible for your own people. That's what gets people feeling safe that they can start something like this, right? They want to know that they've got the autonomy to make their own decisions. We also do not rely on medical reimbursement. So this is private pay. We've got the guide model that is now, I think we're one of the only social organizations in the guide model that's not Medicare, Medicaid. We had to fight to get approval for that, but we did. So we don't depend on big grants again that could possibly disappear. We provide examples. Let me tell you, through 72 churches and senior centers, everybody's got a different hierarchy. They've got a different way that they make decisions. And so we can provide different business plans to help them see where this ministry, where this program can be a part of their community, right? We have to give them different examples. And then we've got peer-to-peer networks. We've got 13 years proven best practices. We share everything for free. You all are just going to help me figure out how to scale it to 1,000 from 100, right? So Secretary Branham asked me to come to represent as an innovation for the state of Florida, and we've got 7 programs there. Florida needs one on every corner with their aging population, right? They need one in every county. This is so low cost. This is a ridiculous thing that we need in every community. Who ever thought that somebody would stand before you and say, did you ever think that the state of Alabama was going to be the leading leader in something this great? We've got 17 volunteer respites across the state of Alabama. Dr. David Gelmacher, many of you might know, head of UAB Neurology, has helped put us on the map. We've got 7 in Birmingham, right around UAB. But we've got them everywhere across our state. They need to be in every state at these numbers. Help me figure out a way to leverage our scalability, right? We predict millions of hours of volunteer service that we will provide in the next 10 to 15 years. We logged 500,000 hours of volunteer time last year, but there will be millions. I predict that there will be hundreds of thousands of caregivers in the next 10 to 15 years that we help. And there will be billions of dollars in economic value from my volunteer team and from keeping our people at home with quality of life years longer. Somebody's going to figure out how to get me that research so I can prove it, but I know it'll work. That's all I got. I hope y'all stand up and stretch, and questions can come later. Thank you.
Thank you so much. Daphne's energy is so infectious, and I'll just read real quickly. Kate just sent a message to me. This presentation is wonderful. I had heard of RFA when I lived in Alabama, but I've been so touched to hear directly Daphne's clear love for patients and families. Just wanted to share that. So thank you so much, Kate, for texting me that. We are going to take a break. As Daphne mentioned, we're going to stretch, and we're going to come back in about 10 minutes and hear from our guide model participant coming up to you next. And then we are almost wrapping up here. So thank you so much. We'll see you in 10 minutes. I'm just going to take a minute or two. Helen is going to grab an expert for us. We're going to talk a little bit about guide. She is going to reluctantly say yes. while we're just filling a little bit of time, what I thought was important, so I can't wait to hear what you all have thought about the speakers. What we were trying to do is focus on care. So we heard about from Rob Egge and public policy, and four action items that Rob gave to us that are very simple but very direct, and how this council, literally how our community, how our members of Congress can get behind the next steps that we want to take to ensure that the people, if we're getting all of the diagnostic tools, all of the monoclonal treatments, the things that we're offering, do we have access to it? Do we have coverage for it? So those are some important things that Rob brought to us. Then we heard from Dr. Rosemary Laird, and we looked at a caregiver model and a navigation tool that sets up caregivers for success. We've done it all over the state of Florida and has been wildly successful, and you saw not just the human response, but also what the numbers look like in reduction of falls, reduction of emergency room visits, and reduction of caregiver stress and burnout. And then finally, I really wanted to connect our community to care. So you heard from Daphne, and it was, I mean, if you listen to the electric sound of Daphne talk about faith-based communities that already exist in every community across America, and how they are a ripe space for us to introduce a very simple model of respite care. So I wanted to thank all of our speakers. And now we wanted to talk, you've heard a couple of our speakers talk about the guide model, so I thought we would round out our caregiver experience by talking a little bit about guide, and then one of our guide model participants. So I'm stalling time. Yep.
All right, so we're so pleased today to be joined by Sarah Irie from the Office of Innovation at CMS, or CMMI. I guess almost 2.5 years ago, we were so thrilled to roll out the guide model at one of our NAPA meetings, and as you'll hear, it sort of takes a little bit of the research, a little bit of the clinical care, a little bit of the long-term services and supports, and certainly a lot of what we heard from caregivers throughout the life of NAPA to this point, and continuing about what they need. And CMMI was able to take all of that together and use their flexibilities and develop the guide model, which is now in the field and is starting to benefit folks in the community, including people living with dementia and their caregivers. So we're putting Sarah a little bit on the spot, but
So you could just sit down if you
want to sit down with us. Yeah.
We put Sarah on the hot seat. Thank you so much, Sarah, for joining us.
There we go. All right, thank you. Thanks for having me. As Helen said, I'm Sarah Erie, joining from the Innovation Center. I co-lead the Guiding and Improved Dementia Experience Model, or GUIDE for short. We love our acronyms at the federal government. So I'll just give a quick background, and I apologize for not having a slide to kind of anchor this to, but bear with me. Okay. So the guide model aims to address existing gaps within our nation's current dementia care landscape by really defining a standardized dementia care delivery program, providing an alternative payment methodology, and addressing caregiver needs, and also paying for respite services. Guide tests whether comprehensive dementia care will improve quality of life for people with dementia and their caregivers, while enabling more patients to remain in their homes and their communities for longer. The model focuses really on 3 core components. The first is care coordination and management. The second is caregiver support and education. And the third is respite. And really these three components work together to address the complex needs that families and providers face when managing dementia care. To support the development of new dementia care programs, Guide launched 2 participant tracks, one for established programs that began on July 1st, 2024, and one for new programs that included a 1-year pre-implementation period, and they began performance on July 1st, 2025. These numbers might be a little bit outdated, but we have roughly 330 participating organizations, and they are in locations in 44 states. About quarter are established programs, and then 3/4 are new programs. But based on kind of reported service areas that these participants cover, guide participants are really delivering services to beneficiaries in all 50 states and the District of Columbia. We anticipate guide will, over the course of, this is an 8-year model test, we anticipate that guide will reach over 200,000 original Medicare patients and their families, making this one of the largest dementia care initiatives in our nation. This does include people who are dually eligible for Medicare and Medicaid, who often experience really fragmented, uncoordinated care. I think if that's enough of a background, I will pass.
Yes,
Okay,
I
great.
think so, absolutely. Thank you so much, Sarah, for joining us and just giving a quick layout of guide. So I really appreciate it. And then I'm going to pass it over to Maria just to discuss introduce our guide presentation for today.
Sure. Our guide participant will be joining us virtually. So 5-Star Home Healthcare, are you online?
Yes, we're here.
Great. Thank you so much.
Hey, Jim, could you introduce your team to us and a little bit about 5-Star?
Yeah, my name is Johnny Wilkinson. I'm the founder and CEO of 5-Star Home Healthcare. We are a in-home provider of healthcare services. We've got a PowerPoint if you want to start that.
Yes, 1 second.
If you go to the next slide. So I wanted to thank the team for inviting us to the Advisory Council. We've had a very good response from our community to the guide program. As the prior speaker said, we were in the established track, so we're almost 2 years into the program with some very positive results that we've been able to get from the program and from our patients to receive them. As a company, we are a healthcare at-home provider treating chronic diseases in the home. You can see on this slide all of the services that we provide encompass Medicare certified home health, as well as Medicare Advantage and the VA. Those are contracts that we have to provide chronic disease management in the home. Something that's unique about what we're able to offer is the integration of the provider house call, as well as daily caregiver work. So the integration of all of these services kind of uniquely positions us to provide great results with a program like Guide, because we're truly providing integrated care and addressing the issue of fragmented care in the home. If you go to the next slide. This is our service area. So we are just outside of DC, directly west of DC, servicing the Northern Virginia market. You go to the next slide. I'll just kind of add a little bit to what she was saying earlier about the Guide program. It started in July of 2024. We started at the beginning. It's a per month, per enrollee program where we're paid a care navigation fee to provide the patient services for care navigation, family education, and teaching of the disease process, as well as support for respite care of the family member, as well as a review of medications. The program requires an in-home assessment for documenting and understanding and teaching them about their medications, a fall risk assessment, a home safety evaluation, and then we create a care plan and contact them at least on a monthly basis to provide resource and connection and better understanding the disease process and how it affects their family. In terms of patient qualification, a dementia diagnosis that's confirmed, Medicare Parts A and B, but unlike most Part B programs, this program does not require a copay or deductible, so they're able to get the service of Guide completely at no cost, not living in a long-term care SNF and not on PACE, hospice, or Medicare Advantage. Although there are some companies out there that provide similar Guide services to Medicare Advantage participants around the country, such as Seresti. The goals of the program are quite specific: having the patient live safely in their home and out of a facility, and to reduce the number of hospitalization visits, reduce the use of long-term care SNF, reduce the stress of the family caregiver, and that's measured quantitatively with the ZBI scoring mechanism, reduce the use of high-risk medications, and to really be a resource to the family in long-term care planning and understanding what are the long-term care resources available, such as when to introduce hospice, when to really kind of organize the types of legal and financial aspects that come into play that are important to someone that's dealing with a chronic disease such as dementia. The next slide. So these are some of our metrics. We've served 209 patients. You can see on the graph, most of our patients are in the moderate tier. The patient referral sources, it's quite varied. Many of them are coming from physician practices. Physicians really kind of view the role they play with managing a patient that has dementia. They're very high maintenance, lots of phone calls to their practice. So we are a valued resource to the physician, whether it's a neurology practice or to a primary care practice, of being the one to receive those calls and being that expert resource that is dealing with the family member and the patient directly or their spouse on a long-term basis and alleviate that burden from the physician practice of having to deal with that. Next slide. So why did our team apply for GUIDE? One of the things that we fundamentally believe is that longitudinal care is the future of chronic care. And the reason that we created sort of the unique aspect of how we exist as a company with both home health and the provider and the daily caregiver, those are the key services in the home to address chronic disease management. And the healthcare system overall is really constructed around episodes and visits. But individuals with chronic diseases are living with those diseases for the rest of their life. So the care needs to really be organized around the fact that they have the disease for a long period of time, but the care needs to be delivered in a way that's longitudinal in nature, not based on an exacerbation of a particular illness or a particular activity. It needs to be on an ongoing basis. So that's why it really aligned to our belief and our vision for what we're doing with our company and how we want to manage the patients in our community, which is a longitudinal way. And that's really where this program comes into play. Next slide. So our results have been quite impressive with what we've been able to do and how we're delivering results for our community. So in our year one results that were published by CMS, compared to similar risk profiles, meaning that patients that have similar cognitive impairments and similar disabilities, for GUIDE enrolled patients, admission to SNF long-term care was 84% less. That's a staggering number to look at in terms of if that holds through other GUIDE participants and similar programs like this. It really does show what longitudinal care can do. The total per capita cost was 29% less. So these are things that we're very optimistic that the program will continue to provide results like this, and we believe that the impact on the community has been quite positive. Next slide. One of the key things that of how we look at this and how we're organized as a company is really the core understanding that no one only has dementia. And according to CMS and many other studies, 75% of dementia patients have 3 or more chronic conditions, such as COPD, cardiovascular disease. These are diseases that we in the home health world and the geriatric population are dealing with all the time. So when you combine the ability for us to deliver all of the other associated services, such as nursing and the provider, all in an organized way, GUIDE is really the glue that holds it together and really that connects and coordinates these programs. Next slide. So what is driving our success is the integration of the care management of all the diseases that the patient is addressing and all of their functional limitations. And as I said earlier, GUIDE is really what connects them and manages that process. Next slide. the fundamental belief that we also have in how we approach our work as a Medicare certified home health agency is that we have to go beyond what is traditionally viewed and how care is delivered in the home. And a lot of the work that we do and that most home health agencies are really evolving to is going beyond simply treating the patient and being done there. We have to teach the family and teach the patient empowerment. And this is where GUIDE comes into play, because it's really guiding the family member to understand the disease process, understand what the issues that they're going to encounter for what is a really long-term chronic disease that they're going to be facing. And the development and the process of the disease is very slow, but educating that family member can have a very positive effect, as you saw earlier on the numbers, in keeping them out of the hospital, keeping them out of SNFs, and enabling them to be safe and functional and comfortable in their own home. Next slide. The key to this is, as that has been talked about most of the day, is that family caregiver. The families that we're dealing with, when we talk to them about GUIDE, they're, as was stated earlier, they're alone, they're confused, they're disconnected from really kind of understanding how the issues are going to affect them, and they really just don't know where to begin. And we are a resource to put some organization behind that and really bring the word accountable to something where they can really see it. Because it's, as I mentioned earlier about how chronic diseases in the state of today's healthcare system is a combination of episodes and visits and admissions to hospitals. Longitudinal care programs like GUIDE really address that. And the front line of those family caregivers, they are the ones that we're really addressing. Of the family caregivers that we're dealing with, about 60% are the spouse of the individual with dementia. The other 40% are typically the children of them. So these are individuals that they're motivated to help. They are willing recipients of the work that we're doing to help them. They have a lot of anxiety over of how the disease is progressing. It's affecting their own personal life. It's affecting their work life. So the more we can do to address helping them understand it, helping them understand what's normal, what the process is like, it's going to go a long way to improving the life and the ability for those family members to contribute and have less stress in how they're dealing with it. The next slide. These family caregivers are critical in reducing unnecessary hospitalizations. They are the first ones to identify and detect changes. So whether it's a change in mental status, a change in bowel movements, urination, loss of appetite, weight loss, gain, a fall, if they're starting to get sick, they're not acting their normal self. These are things that can be identified, and we can involve our provider, involve nursing, take a look at if their medications need to be changed, so that educating that family caregiver on what is a normal disease process for dementia and what is another medical illness. These are things where we can better manage that through having a long-term relationship with that patient and not waiting until something happens or waiting until the exacerbation happens. Then they go to the emergency room, then they're admitted to the hospital, then they go to long-term care SNF. We're hopefully eliminating that cycle from occurring in the first place. Next slide. The most popular feature is respite care. So I think the fact that the spouse or the child is able to have some just alone time, as was stated earlier from your prior speaker. They are having someone to be with their loved one while they're doing an event or going to a doctor's appointment or going out of town. It's a great stress reliever to have respite offered to patients that or to the family members or the family caregivers that are caring for someone that has a dementia diagnosis. Next slide. I want to turn it over to Jody Lyon. She has been our partner in the GUIDE program from the very beginning. She is our lead care navigator and trainer, and she's going to talk about just a few examples of case studies and just kind of sum up the program for us with a SWOT analysis. Jody?
Hi, everybody. If you could go to the next slide, please, I'd appreciate it. Thank you. Good to see all of you. I'm used to attending the NAPA meetings in person, so I'm feeling a little little more comfortable in the house right now. So I want to talk about some case studies. All of us know the statistics behind them, but I wanted to add a little of the humanity to it. So the first was a caregiver I personally was on the phone with. His wife had Lewy body dementia. And he said to me very calmly in the middle of our usual monthly care call, you know, when I hang up with you, I think I'm going to call 911. Now, my first thought was, if you need to call 911, why are you on the phone with me? I'm not a doctor, you know, hang up and call 911. And I said, so why are you going to call 911? Well, he was very aware that his wife had Lewy body dementia. His doctor had done a wonderful job explaining what to expect with Lewy body dementia, but his wife was eating lunch while he was on the phone with me, and she was having conversations with the invisible small children at the table, telling them that they need to finish eating their sandwiches. And he said to me, well, there aren't any kids at the table, and she's having these entire conversations, so obviously I need to call 911 because she's hallucinating. And I asked him if this was the first time it had happened, and he said no. And I said, and what did the doctors say to you about these hallucinations? And he said, well, that they're a normal part of Lewy body dementia. I said, okay, and is she upset or agitated? And he said, no, she's eating lunch. And I said, then why are you calling 911? And he stopped for a minute and he said, I don't know. I really don't know why I'm calling 911. And I said, if she's not upset and it's normal and it's not a change in status, why would you call 911? And he didn't. And instead, he did call the doctor, who said, by the way, that's normal, and just go with it. And next time, see if the kids want any juice and just go along with a hallucination. So that was an avoided 911 call due to a relationship with a care navigator and the family member, where the calmness and the education avoided the screaming ambulance lights, the disorientation, hospitalization, etc. On the other hand, there's a case study. The next one is someone with frontotemporal dementia and the need for a safety plan. As many of you know, people with frontotemporal dementia can lose their ability for executive functioning, judgment, and emotional response. And they can sometimes get violent when they are pressed or nervous, etc. And so there's always a need to have an emergency plan in place, a go bag, for example. So I always ask my clients who are caregiving for somebody with FTD to please have all of their important papers, some of their medication and things like that stored outside of the house somewhere safe. Think along the lines of, if there's a fire, you're not supposed to stand in the house calling 911. You're supposed to get to safety and then look for help. I had two terrifying incidents. Each time it was a male client with a wife who had FTD, and each time the clients very specifically used the words, "She never hit me." I've now learned to change the word hit to push, shove, cornered, make you feel aggressive, make you feel that they're being aggressive, are you feeling trapped, etc. Both of the men involved, with their two separate wives, each had been shoved down a flight of stairs by their wives with FTD, but they literally would say, "She never hit me," as if the punching or hitting was the problem. So again, part of our care navigation and our care plans is making sure there's a safety plan in place to keep the family caregiver and the person with dementia safe. And then finally, this was something that I think was surprising to a lot of us, which was the need for referrals to financial advisors and attorneys for everybody to make short-term, medium-term, and long-term plans. Even the really wealthy people who could afford to pay for anything don't know where to look for help, don't know how to financially plan for the future, don't know how to legally plan for the future, and don't have a backup plan in place. And I know speakers before me have said this, and I can't reiterate it enough. Everybody needs a backup plan. This cannot all be dependent on one family caregiver. So we have found that when we have the legal and the financial pieces involved, people can make a plan and they don't end up in a nursing home on Medicaid by default. It would have to be something else having happened to cause that to be the result. So again, even the wealthy don't know exactly where to go, even if they could afford it. Next slide, please. So let's talk for a minute about where GUIDE stands in the real world. So there are some really good strengths. Longitudinal care works. We know that we're saving taxpayer saving taxpayer money. We're doing pretty well at debunking denial myths, like my loved one still remembers me, so they must be okay, or my loved one doesn't wander, and all of us care navigators say hasn't wandered yet. And we know that the family planning reduces the anxiety, getting the legal and the financial plans in place, understanding what to expect, trying to avoid surprises. That is very, very much a strength. But there are some real weaknesses. Number one, the GUIDE program starts too late in the disease process. So you saw from our earlier stats, most of our patients were at moderate stage. We need to expand to mild cognitive impairment, or even before that, to the worried well. The people who think something's going wrong with their brain are probably right, but they're not actually included in the GUIDE program. The second weakness, and I know everybody here can understand this, families want and need more respite care. Caregiver burnout is real, and we all know the statistics about how much caregiver burnout costs Medicare when the family caregiver gets ill. And one of the other weaknesses is it takes a lot for us to onboard somebody into the GUIDE program. It is rather bureaucratic. We have backlogs of people trying to get into the program, and we would love to get that smoothed out a little bit. So there are opportunities. One is, if we get involved earlier in the disease process, can we delay the onset of when the dementia symptoms show up? We are grateful for the Medicare outreach letters to beneficiaries. Those did work. And one thing that we've noticed, which probably isn't a surprise to the people on this call, there's a real need for brain health education for the providers. We've offered some CME accredited education programs. There's a big need for more, so that medical professionals at whatever level who are coming in contact with older adults need to know about brain health, dementia, and the GUIDE program. What are our biggest threats? The first is that it's really hard to get into a neurologist to get your testing done. There's a huge backlog. We all know this. One of the others, and to be honest, this is the bane of my existence, the myths that are prevalent on social media. I know I'm not alone in saying this. We need to get good information out through social media to combat the myths that are out there. There's a group of us GUIDE participants who get together on a regular basis. All of us are very, very willing to help this committee and CMMI and CMS help to spread the word about good, solid, evidence-based information get it out on social media to try to combat some of the myths. So we stand ready to help. But that's the basics of the strengths and weaknesses. The program is successful. It is working. People are happy with it. We would like to be able to expand. Part of that expansion is making it a little bit easier for us to onboard people, and education and outreach to medical professionals so that they know about the program so that they can refer back to us. Next slide, please. And I think that's back to you, Johnny, for questions. We're able to take questions.
So, thank you, John and team. And I'm sorry, John, I said Jim. So John and team, I really appreciate the very thorough presentation. What we're going to do at this time is I kind of gave you a quick review of all of our presenters, but I'm going to go ahead and give us about 20 minutes or so to just open the floor to Q&A to any of our presenters. So again, we had Rob Egge from the Alzheimer's Association, Dr. Rosemary Laird of NAN Cares. We had Daphne from Respite for All, and certainly John Whittington and team from 5 Star Home Health, who is our guide model presentation. Any questions? I know Steve had some comments for me. Steve, would you want to share with the group too just the comment we made during the break that you thought was really important from Rob's presentation?
About taking action on this ourselves. Yeah, it's probably the most critical thing we could do today is to take action to support the ASAP program.
Helen said not today, but a day, very soon in the future.
Yeah,
not while you're a special government employee. Sorry.
But to support his program and get that done. We talk about right from the beginning. We talk about how do we get something done here. That's something we can absolutely take action on quickly.
I agree. I think Rob gave us a really good 4-pillar roadmap to be thinking about, and at least 3 or 4 people came up to me during the break to talk about that. So yes, Steve, I agree. Chrissy, did you have a comment too?
Just second that, and not today, Helen, but I think that one of the things that we can do from our perspectives is go back to our respective states too, because when states start to talk about, and state leadership starts to talk about this to their federal delegations, it creates that momentum that helps push things along.
Anyone else? Okay, I just want to remind us too, so just a quick, since we have just a minute or two, let me, before we get into public comment, because I think we're going to get us out on time. Maria's like, yes, we will. Because we do have a lot of public comment we did last time, so I just want to make sure we leave plenty of time, get us all out on time. But again, the work is going to happen, a lot of work is going to happen in the subcommittee. So I'm looking at you, chairs, talking to you online to make sure that if there's any questions we have, right now, today we focused on care. We heard a lot about policy, but today was about care. Next time, when we have our meeting in July, we're going to focus on research. And I talked to Dr. Bateman and Dr. Weiss about that, so the theme will be on research. And we'll keep going with those different themes so we can spend a lot of good time in one part of the plan each time we come together. But in those subcommittees, I'm going to challenge us, and each part is different. So you've got a subcommittee chair for risk reduction, long-term care services, clinical care, and research. So we're going to dive into those. If you want to ask questions of any of our presenters from last time, this time, if you want any presenters at your committee meetings, you're going to meet about monthly, maybe more than monthly, because we have a lot we want to accomplish. We're hoping to accomplish it in July. We're going to make Maria smile real big if we get it done in July. So I'm really hoping that we can. I know we started a little bit late, but we put together, I talked about all the presentation materials and things that we put together to really build the frame that we want to discuss for those recommendations and then go straight for them. We want to make them short. We want to make them concise. We want to make them action-driven. Rob was an inspiration for that, so we saw some of that really take hold today. So just want to give that charge out to our subcommittees and just assure you that I'm here. Ping me if you have any questions, if you want any information from any of the presenters today. That being said, if there aren't any additional questions, I think we can go into public comment, can't we, Maria?
Sure.
And a big thank you again to all of our presenters, and thank you to the audience for coming today. I thought it was such a good and exciting time and I agree with Rob and all of our presenters, and I think Dr. Rosemary Laird said it too. This is our time, folks. This is the time. I have never been so excited and felt so electric about the work that we can do, and I've been in this space a long time. Phil's smiling at me because he knows it's true. This is our time for Alzheimer's disease, and we are on the precipice of it. So let's make much of it while we have it. We have glorious people in the room, far more intelligent than I am, doing this kind of work in research and clinical care, and that is really energetic and enthusiastic about what we're looking at for the future, and we're ready to take care of the people while we're doing that research. But the policy needs to happen now. You've heard it, and we've got all of the right tools in place to really ask Congress to do the work, to create the statements, to do the things that we need to do. So just want to thank you and give you that great big charge and tell you to get your running shoes on, because the time is now. And we need to be at the ready. So this is our time to make much of it, and I look forward to hearing from all the subcommittees. And with that, I will pass it back to Maria for public comment.
Thank you, Michelle. Okay, we're going to start with folks that are in the room with us today. So we'll start with the LEAD Coalition. Ian Kramer.
Good afternoon, everybody. I'm Ian. I'm not sure if this is on. It is? Okay. And I've broken the microphone already. Good afternoon, everybody. I'm Ian Kramer, Executive Director of the LEAD Coalition. Shari Ling is kind enough to begin passing around the table a copy of the LEAD Coalition's fiscal 2027 Congressional Appropriations Letter. I won't ask you to read it cover to cover, but I will note that it is broken down into sections for many of the agencies around this table that are represented on the NAPA Advisory Council, and gives you an overview in each section about the funding that we are recommending to Congress in our community. And we would certainly welcome the support of the Advisory Council for these recommendations, but funding to help through the lens and the prism of the NAPA Advisory Council's interagency collaboration, the resources that are necessary to make sure that each of these agencies, NIH, CMS, ACL, HRSA, and others, have the capacity both in dollars but also in people to accomplish the work that the NAPA Advisory Council wants to get done, that the national plan envisions getting done, to make this a better world for people at risk for cognitive impairment, living with cognitive impairment, and for those who are trying to support them through the advancement of science and the provision of social services. On page 3, you'll see a bulleted summary of those asks, but then the deeper dive in the body of the letter. In the interest of time, I'm just going to flag 3 additional pieces of legislation with a great big thank you to Rob Egge for the deep dive on the ASAP Act. That is another one, and we'll provide the LEAD Coalition's letter to Congress in support of the ASAP Act. We'll provide that to Helen and Maria Teresa to circulate to all of you in electronic form. But in the same way that on our appropriations letter, you'll see north of 450 researchers and advocacy organizations and industry members and trade associations and professional societies and other sectors represented in support of our appropriations asks to Congress. You'll see that on our ASAP letter as well. And not least among them, I'm very pleased to say that the Alzheimer's Association and Alzheimer's Impact Movement, through Rob's leadership, are supportive of both of those letters. We will also provide electronically a copy of our letter in support of something called the Change Act. And again, this is one of those very practical things that the NAPA Advisory Council can ask Congress to do to make an immediate difference in the quality of lives of people facing cognitive impairment, Alzheimer's disease, or related disorders. The Change Act, and I'm oversimplifying a bit, but it's not a very complicated piece of legislation. In essence, what it would do is say, for any physician or healthcare provider who is providing the annual wellness visit or welcome to Medicare visit cognitive assessment, which is a free benefit under CMS law, they have to use a validated instrument to do that cognitive assessment. It's not a big lift. It's just saying if you have a choice between an unvalidated instrument, the eye test, if you will, I think I know dementia when I see it, versus using a validated instrument, the clinician and their patient and all those in the ecosystem of their patient are better off if it's a validated instrument. So it's just asking CMS to empower clinicians to use those validated instruments rather than to leave those clinicians to their own devices to maybe use something validated and maybe not. The last piece of legislation I'd like to highlight for you, again, a very practical step and one that is well within the authority of Congress to change the lives of real people on day one after this law might be signed in, this legislation might be signed into law, is something called the Bridge Act. You had some discussion earlier today about young onset Alzheimer's disease and related forms of dementia. We all know people or know of people who have experienced the enormous hardships of getting this diagnosis before age 65, before normal availability of Medicare benefits and services. And as much as people at and above 65 need access, people under 65 might need it even more and have a harder time coming by those services and supports that they need. What the Bridge Act would do is say, if you are under age 65 and you are able to qualify for Social Security, disability, and Medicare coverage, you won't face a 24 to 29-month wait period under law. So it's exactly the same kind of protection that was extended to the ALS community, and all the Bridge Act would do is extend that to the Alzheimer's community as well. So it's not an enormous number of people, but it is a group of people who have desperate need and would enormously benefit from that fundamental change in law to provide them the same access to services at a younger onset age as they would be entitled to at a traditional age of Medicare eligibility. They just wouldn't have to face that 2+ year waiting period. And that's again called the Bridge Act, and we'll provide follow-up information in electronic form to the council about that. So thank you for your attention. Thank you for your deliberative and forward-charging work. And please know that the LEAD Coalition collectively and all our individual member and allied organizations are here as allies to you and all the work you're leading. Thank you.
Thank you so much, Ian. And we will turn now to Carrie Edwards with the Association for Frontotemporal Degeneration. Okay, can you...
Hi there, can you hear me?
Yes.
Hi, thank you for having me today. I am the ambassador volunteer for the state of Virginia for the Association of Frontotemporal Dementia. And my husband, Captain Steve Edwards, was at the Pentagon on September 11th, and he was battalion chief. He worked the burn pits, and years later, he got a non-genetic form of FTD that Bruce Willis has, the same thing, and he passed away in his early 60s, was diagnosed in his mid to late 50s. And so I'm here to bring FTD awareness to the table, and I'm sure you've discussed it as a related disease, but we very much are supporting and advocating for the Healthy Brain Act so we can start to track the environmental exposures that can happen and create degenerating cognitive decline. So thank you.
Thank you so much. And we will now turn to, I'm going to apologize in advance if I butcher your name, Dr. Sudhir Sivakumaran. Are you available?
Yes. Hi. Good afternoon, everyone. Can you hear me fine?
Yes, we can.
Yeah. Thank you for the opportunity to speak. I want to begin by acknowledging the importance and impact of the National Alzheimer's Project Act. NAPA has played a critical role in advancing Alzheimer's disease research, care, and awareness. The progress we have seen over the past decade, particularly in biomarkers, diagnostics, and emerging therapies, reflects that leadership. At the same time, science has evolved. Dementia is not a single disease. It is a spectrum of neurodegenerative conditions, often with overlapping pathologies. Mixed pathology is the rule and not the exception. Analysis from ADRC datasets suggests that only a small proportion of individuals present with pure Alzheimer's disease. Many of the challenges we face are therefore not unique to one disease alone. Nowhere is this more evident than in Lewy body dementia. Lewy body dementia is one of the most common dementias, yet it remains underdiagnosed, frequently misdiagnosed, and poorly understood in clinical practice. Patients often go years without an accurate diagnosis. Symptoms span cognitive, psychiatric, sleep, and motor domains, but our systems are not designed to recognize or manage that complexity. Across the ecosystem, we see consistent gaps: fragmented data, limited harmonization, lack of trial-ready infrastructure, insufficient diagnostic tools in real-world settings, and a disconnect between scientific advances and patient access. If we are serious about improving outcomes, the next phase of NAPA should build on its strong foundation while more fully reflecting the broader neurodegenerative landscape, one that accounts for biological complexity, co-pathology, and real-world patient experience. This includes prioritizing integrated data infrastructure, fit-for-purpose biomarkers, accurate and accessible diagnosis, and trial-ready systems that span diseases, not silos. The science is ready, and the patients are waiting. The question is whether our strategy will keep pace. Thank you again for this opportunity to comment here.
Thank you so much, Sudhir. And we will now turn to disability rights advocate and actor, Deshil Mayer.
Hi, my name is Deshil Mayer. I'm a filmmaker, college student, actor, and disability rights advocate. I also have Trisomy 21 Down syndrome. I am a National Down Syndrome Society ambassador and a member of the Stanford University Alzheimer's Down Syndrome Working Group. I want to thank everyone here for considering including Down syndrome in the policies about Alzheimer's, because this disease is very concerning for people like me and our families. People with Down syndrome have 90% chance of getting Alzheimer's in our lifetime. It is the #1 cause of death for us, and we get it earlier than typical people. I have been working closely with the Stanford Alzheimer's Down Syndrome Working Group. In the working group, we look at data and talk about articles. I would love to help to find a way to prevent Alzheimer's from entering the brains of people with Down syndrome and anyone else. I have also learned from the National Down Syndrome Society that it is really important to include people with Down syndrome in Alzheimer's research, because we have 3 copies of chromosome 21. Studies have found that chromosome 21 carries the amyloid precursor protein gene, so we get the plaques in our brains. People with Down syndrome should be included in research and policy making because our lives are important, and studying and helping us can help everyone. We can all have better health and live longer and have great lives together. Thank you.
Thank you so much. Okay, and now we will move to Dr. Keith Fargo with the Lewy Body Dementia Association. Dr. Fargo, are you on? No, we were
Yes, I am. Yeah, thank you very much. Good afternoon, everyone. My name is Keith Fargo, and I'm the Director of scientific initiatives at the Lewy Body Dementia Association. LBDA is the nation's leading organization dedicated to Lewy body dementia, or LBD, which is the second most common form of neurodegenerative dementia. LBD encompasses both dementia with Lewy bodies and Parkinson's disease dementia, affecting approximately 1.4 million Americans. Pardon me. I want to begin by thanking this council for its sustained commitment to the field. The approval of disease-modifying therapies for Alzheimer's represents a historic achievement, one that this council helped make possible through years of coordination and policy leadership. We celebrate that progress with you and with all Americans affected by dementia. We also want to acknowledge the council's growing attention to co-pathology and multi-etiology dementia. This is crucially important work. The overwhelming majority of people living with dementia carry more than one pathology, and LBD, which involves alpha-synuclein, tau, and often amyloid, sits at the center of that complexity. But that complexity is also an opportunity. Research into LBD holds promise not only for those living with Lewy body dementias, but also for the millions more living with Alzheimer's disease and Parkinson's disease. LBDA's Research Centers of Excellence, a network of 27 sites at major medical institutions, overlaps with both the Alzheimer's Disease Research Centers and sites participating in the Parkinson's Progression Markers Initiative, reflecting exactly the kinds of cross-disease and cross-sector collaboration that this council has championed. We are further encouraged that donanemab is now being trialed in a clinical trial in LBD. We urge this council to continue prioritizing research into new diagnostics and therapeutics for multi-etiology dementia, and LBDA commits to continuing our partnership with you in that critical effort. Thank you.
Thank you so much. And we will now move to Lori Reynolds, who will be speaking on behalf of the Frapoli family. Lori, are you on? We can't hear you.
There we go. Okay, can you hear me? Okay. Good afternoon, and thank you for the opportunity to speak. My name is Lori Reynolds. I am here today as a caregiver, but also as a sister. I come from a large family, 6 siblings in all, 3 brothers and 3 sisters, and we all love each other fiercely. 2 of my brothers, in particular, are why I am here today. One of my brothers, Carlo, is a past board chair of the National Down Syndrome Society. My other brother, Joe, has Down syndrome. If you know anything about Down syndrome, you know this isn't unusual. People like Joe face a much higher risk of Alzheimer's, often decades earlier than the general population. And yet, too often, the systems meant to support people with dementia are not built with them in mind. I am Joe's primary caregiver. I'm doing everything I can. I've been able to hire help who comes a few hours each day, but I know I'm one of the lucky ones because finding that help wasn't easy. Most caregivers and home health aides have little to no experience supporting people with Down syndrome. There is no built-in training, no standard preparation. You have to find someone who is willing to learn, and that takes time, energy, and resources that families are already stretched thin trying to provide. And even when care needs increase, families face another barrier. Many long-term care and memory care facilities are simply not prepared or willing to support individuals with Down syndrome because of their unique needs. So families like mine are left asking, where do we go? I carry this every day. I am exhausted, I am worried, and I am heartbroken watching my brother slowly change. This is what long-term care really looks like for families, not just logistics, but love stretched to its limits. That's why I'm here to ask you to ensure that long-term services and supports are truly inclusive of people with Down syndrome. Inclusion means recognizing different needs, not ignoring them. It means training providers who understand both intellectual disability and dementia. It means making sure people like Joe are welcomed, not turned away when they need higher levels of care. And it means ensuring families can access support before they reach a breaking point. Because right now, too many families are navigating this alone in systems that were never designed for them. Joe deserves better. Families like mine deserve better. Please make inclusion a priority, not an afterthought in the National Alzheimer's Plan. Thank you.
Thank you, Lori. I I believe we have one more commenter, Ron Epps with the International Association for Indigenous Aging.
I am not nearly as tall as Ian. Okay, here we go. Ooh. I want to thank all of you for being a member of this council. I know it takes time and appreciate that. The International Association for Indigenous Aging, or IA Squared, is part of the CDC Healthy Brain Initiative. Our team has helped American Indian and Alaska Native communities build brain health awareness, focusing on their elders. These communities truly are the first Americans. I am proud to say that progress has been made. For these first Americans, there is now a roadmap for public health agencies to use to support discussion about dementia and caregiving, as Captain Lastalat with the CDC mentioned earlier. There are healthy food, healthy brain rat cards, flyers describing how to reduce your risk of getting dementia, videos like the River Story that describes the journey that is traveled. Dr. Ling mentioned the 4Ms framework. We've adapted that 4Ms framework to be more appropriate for American Indian, Alaska Native communities, and I'm proud to say that it's being used across the country. Many other materials that I'm not going to go through all of those, including one of my favorites, which is Dementia Bingo.
Hello?
Dementia Bingo, which I kind of wish we had time to play Dementia Bingo right now. That'd be fun. Perhaps best of all, there are real conversations taking place among health professionals, elders, and families in these corporations, pueblos, tribes, and nations. This work helps to fulfill the legal treaty obligations the United States has to these communities. And there is more work to be done. There are 575 federally recognized tribes. In addition, there are many people from tribes that have not reached the status of federal recognition, including Native Hawaiians. Reaching and serving all of these populations, recognized or not, can be challenging because of physical geography, language, and cultural differences. These past 5+ years of the HBI work has shown that focusing efforts to create materials and strategies for these tribal communities is effective. The elders in these communities touched by the Healthy Brain Initiative are aware of and practicing the actions that can reduce risks and build healthier habits. Families and communities are beginning to understand caregiving strategies. As I look at the flags that are around the top of the walls here of the room, it reminds me that this work is showing positive results, and it would be a mistake, in my opinion, to fail to continue it. I ask the members of this advisory council, you, to remember these first Americans as you continue your work. Thank you very much.
Thank you. Thank you so much. If I could, too, for all of our presenters, I'd love to get a picture up on stage with all of us. I think that would just be a nice way to commemorate today. Again, I appreciate it. So we know the charge, folks. How do we feel, Council? I see some heads nodding, and I do hear the energy. I'm so grateful for the public comments. We don't want to forget anyone. I appreciate everybody being represented today. Just wanted to say again a big thank you to Maria and to Helen for all the work to get us here today. I'm going to look forward to us in July, and in the meantime, we've got a lot of work ahead of us, and I'll look forward to hearing much from our subcommittees, right? Okay, good. And with that being said, we'll close today. Many thanks, safe travels to all. I really appreciate you spending today with us. Thank you.
Produced by the U.S. Department of Health and Human Services.